All right. Good evening, everyone. Or good evening. I'm used to doing these in the evening. Good afternoon. Welcome to Woo You. Tonight we have a special event, the Scleral Lens Summit. And to kick off the Scleral Lens Summit, we get to hear from Doctors Jamie Kuzner and Doctors Jason Jedlicka. And they're going to be talking on shaping the future, advances in scleral lenses. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Bausch& Lomb for supporting this event. This will be worth 1 hour of CE, so please be sure to attend for a minimum of 50 minutes. For your COPE certificate, please fill out the survey link that will be in the chat shortly, and it'll also be there when the webinar ends. CE certificates will be delivered via email and sent to Arvo with your OE tracker numbers. We'll also have a QR code at the end of the event so you can scan your OE tracker app and get your credit instantly. CE certificates will be emailed within 4 weeks. If you have any questions, please ask them in the chat area or in the Q&A located at the bottom. And then if you're on your phone, you can find the Q&A at the top and then the chat feature under those three dots under more. So I'm very excited to introduce our speakers tonight. Got to hang out with them this last weekend at ICSC. So first up is Dr. Jedlicka. He's a professor at Indiana University School of Optometry and the director of Cornea and Contact Lens Service. He's a diplomate in the American Academy of Optometry's Cornea, Contact Lens, and Refractive Technologies section, a past president of the Scleral Lens Education Society, and a fellow and board member of the Contact Lens Society of America. Contributed to multiple textbooks as an author on the topic of GP lenses and was awarded the 2016 Sober Award for Contact Lens Education, GPLI Practitioner of the Year for 2021, and the Scleral Lens Education Society Scleral Practitioner of the Year for 2023, as well as the 2024 GPLI Educator of the Year. He is the co-developer of the Zenlens Scleral Lens and Delta Scleral Lens. These are his financial disclosures. And then Dr. Jamie Kuzner, she's the founder of Elevate Eye Care and Eyewear in Rochester Hills, Michigan, earned her doctorate of optometry at Michigan College of Optometry, Ferris State University, and completed a corneal disease and contact lens residency at Indiana University. She specializes in fitting GP and scleral lenses, myopia management, and orthokeratology design. She has received numerous awards, including the Clinical Excellence in GP Gas Permeable Contact Lens Award, and is recognized as one of the Newsweek's top eye doctors in America for 3 consecutive years. She's a fellow of the Scleral Lens Society and the American Academy of Optometry and lectures nationally and internationally on specialty contact lenses, dry eye, and keratoconus. Here are her financial disclosures, and all of which have been mitigated. So I'll have you guys take it from here. Thank you, guys.
Thanks, Ariel, and thank you all for being with us today on this lovely Sunday morning. I hope it's nicer where you are than it is for me because it's a rainy, dreary morning. I'm joined by my friend and colleague, Jamie Kuzner, and we're going to go through this morning, this first hour, talking about some advancements in scleral lens fitting and thinking and whatnot so that we can give our patients who need scleral lenses a better outcomes. So, one of the things that I think we have to recognize that when we fit a scleral lens, of course, this is obvious, right? We're vaulting the cornea. We don't compress the limbus. I say we don't land on the limbus or we don't touch the limbus. Um, I, what do you think, Jamie? Can we touch the limbus?
I'm okay with touching the limbus. Maybe feather
So
touch.
it's a wild place, you know that, right?
It is
So,
a wild place.
yeah. So anyway, we're going to say we don't compress the limbus. We don't want to put undue pressure or force or weight on the limbus. And then we want to align the sclera. And the aligning the sclera is kind of the hard part. And a lot of the times it's the hard part because we're just not thinking about how we get that alignment the right way. And so that's what we're going to talk about for the first part of this is we're going to talk about how to change your thinking to get scleral alignment. And it's not necessarily working with the scleral zone of your lens when we good alignment, we get issues, right? We get like blanching in one meridian and lift in the other. We get compression, we get decentration, we get fogging, all sorts of stuff that is the bane of our scleral lens fitting existence. So we'd love to minimize these complications. If you recall from optometry school, for some of you not too long ago, for me decades ago, the anterior eye, the cornea and the sclera are relatively continuous tissue, right? I mean, if you follow the cornea through to the sclera, it's pretty much a straight line there. Now, the conjunctiva overlies the sclera, and that's what's kind of crazy and unpredictable and can be squishy, spongy, puffy, flat, just depends on the day and what's going on with that
Mm,
eyeball. And so when we measure the shape of an eye, we get to see the corneal shape, but we don't really get to see the scleral shape. We actually kind of see the conjunctival shape, which overlies the scleral shape, which derives a lot of its shape from the sclera, but not entirely. And so again, the sclera gives it shape to the eye, but ultimately the conjunctiva has an influence on what we're seeing. So we look at ocular surface shape, again, just to kind of summarize, the cornea has a pretty fixed shape, right? The sclera also has a pretty fixed shape, and the conjunctival thickness can vary and affect the scleral shape. Just something to keep in mind as we work through this, that conjunctiva creates a day-to-day, hour-to-hour, even maybe variability in how our lens fits. When we measure the ocular surface shape, we've got instruments now that we can do that with. They are either reflection-based systems or Scheimpflug photography systems. The reflection-based systems do rely on fluorescein because they're tear layer dependent and because we don't get good reflectivity off of the conjunctiva and scleral surface. And so, unlike a corneal topographer that's reflection based, where we don't need fluorescein, we do need it with scleral profilometry. So, for reflection based systems, we do need to put fluorescein in the eye. They are tear layer dependent, which does create some variability, just like it would for a corneal topography. So, something to keep in mind that it is possible to get a good scan and a bad scan. And when we're looking at ocular surface shape, we don't want to get bad scans. Scheinflug systems are not fluorescein dependent and or don't require it, and therefore they are not tear layer dependent. So that is one of the advantages there. You will see a little less variability, I think, in Scheinflug imaging systems. And just to kind of wrap up this whole idea, the quality of your maps makes a huge difference, especially as we're looking at if you have this technology, if you're thinking about getting it and you want to use this in either your diagnostic fitting to be more efficient, or if you want to actually export the map into some software and let the software do your lens design, the quality of your map is everything. Okay. These two images are the same eyeball. They're the same eye taken in consecutive moments, so literally a minute apart. The one on the left was taken at 3:41 p.m., the one on the right, 3:42 p.m. Big difference, right? If we use the one on the right to make a lens, it's going to be a bad lens. We've got a lot of artifact there. We've got a lot of tear breakup that's affecting the quality of our scan. The one on the left looks great, and I would completely trust that one for lens design. But this is just to say that all the instruments in the world can't help you be more efficient if you're not getting good data when you use them.
Do you have any recommendations on getting good maps for some of us just jumping into profilometry?
Practice. And I think you got to find your sweet spot for holding lids. Certainly, I think
Hmm.
that when you take and pull someone's eyelids apart, if you put too much pressure on the lid wiper as you lift the lids apart, you're going to drag fluorescein off of the surface of the eye, and you're going to leave bare spots.
Yep.
At the same time, if you use like a lubricant to help make the fluorescein hang on the eye longer, you then run the risk of having that thicker liquid form elevated blotches across the surface. And so it's tricky. It's tricky. I mean, using anesthetic helps because the patient's less likely then to fight you as you try to get their eyes apart. But that also causes some tear breakup. So I think you find your sweet spot over time. And I've seen folks who work with the companies who make these things are so good at getting maps. But they do that every day. So how about you?
Well, I think the thing that's the biggest hurdle for my practice is, if someone comes in wearing a scleral, you need to remember that if they take that lens off, it's going to take days for that eye to really rebound, to get an accurate data. So that's kind of the tricky part for me. What I always encourage you, if you have a scleral topographer, try to get that baseline map on visit one before you ever put a lens in the eye, because that's going to be, in my opinion, like the most accurate. Because if you try to go back and troubleshoot after you've already had them wear a lens for a couple weeks that doesn't fit well, and then you have to wash it back out, it's more complicated. So I always try to get really good baseline data, whether or not I think I'm going to need a really custom lens for my patient. That way I have it to look back on in case I need to troubleshoot.
Yeah, that's a good point because you will, on rare occasion, you may find the need to go back and say, you know what, this first lens that I was fitting didn't work and I need to switch
Mm-hmm.
to something different. But I've got baseline data that's the same now as it was back then. And so you can go back and use that map later if you need to switch boats in the middle of the stream kind of thing. So
Mm-hmm.
I totally agree.
Yeah, but
Um,
even if someone's wearing a lens, it's kind of nice. And we're going to talk about not only looking at the sclera and the conjunctiva, but kind of looking at that limbal area.
yeah,
So even if someone is wearing a lens, I can at least get limbal data. That's pretty helpful, even if I'm not using the entire map. But we'll kind of talk about that in a few slides as well.
sure. So the one thing that scleral topography definitely shows us, and this is something we kind of know already, but like if you look at this image on the right, you'll see, the cornea shape there, and then you'll see this dashed line and this red ring kind of thing, and all of a sudden the color changes abruptly. And then the sclera has its own kind of color pattern. And that's because the cornea and sclera are being presented to us on different reference spheres. And so this is not a continuous map. There's not really a red ring there, so to speak. It's just that the cornea is presented on one reference and the sclera on a different reference. So it's fine. If you look up above in the purple box there, it shows you the best fit sphere of the cornea is 8.3 and the sclera is 11.2. What it tells you is just that the tissues have a fairly different or quite a different shape. And so as we vault over the cornea and we land on the eye with our scleral lens, we've got to remember we are not landing on the cornea, we are landing on the sclera. Okay. But there's a significant transition in shape there, and our lenses have that built into them. And there's a junction point where we go from vaulting to landing. That's a relatively abrupt change in our lens shape, and that's a critical part of this. Okay. So the two different reference spheres really just points out to the fact that the cornea and the sclera are quite different in their shape. When we do look at scleral maps, we can tell that scleras can be all over the place in terms of shape. It's not like corneas where most of them are with the rule or pretty spherical. Scleras are all over the place. We can see a picture on the left of an against the rule scleral shape. We can see the center or fairly spherical eye, and on the right of with the rule. And oblique is all over the place too with scleral topography. We can see asymmetric scans where we have a picture on the left of like a quadrant specific looking eye where one quadrant is elevated, the other three are looks pretty symmetric. And we can see focal elevations too, like a pinguecula, like a tube under or under the conj, like in the sclera. We can see a filtering bleb, things like that will show up on our maps as focal elevations. So scleral topography, not only does it help us to do a better job fitting, it informs us about the eye in general in ways that are helpful to us to better understand how to make better scleral lenses. So let's talk about scleral lens design now for a minute. Remember that scleral lenses are designed to vault the cornea and the limbus to an extent, and then they are to transition from vaulting to landing. All right. And if you look at the little picture on the right, hope everybody can see, we've got this little red section on our image of a contact lens, of a scleral lens. That red section, in the middle of that red section, there's a fairly abrupt change in curvature. Okay. And that is exactly how scleral lenses are made. And that fairly abrupt curvature change point is known. This is, after all, a contact lens with known curve widths and radii. And so we know where that point lands on any given eye. And the reality is that if you're fitting a standard scleral lens, which is spherical in shape, it it's going to have the same sagittal depth at that junction all the way around 360. Okay. But if you look at scleral maps over and over and over again, you'll realize that there's no eyeball on Earth that has the same sagittal depth at that core diameter 360 around the eyeball. In fact, most of them are pretty toric or irregular in shape. And so the difficulty is when we fit a spherical chambered scleral lens on a non-spherical ocular surface, we end up with gaps. We end up with gaps in our fit. And those gaps are what create those issues with poor alignment, like fogging, like decentration, like focal compression, or like indentations on our eye when we move our lenses, because we're getting a lot of pressure in the eye in a very small surface area. So, Jamie, what do you think about this topography? What do you see when you look at this map that's important for us?
Well, I think it's important to look at too, for those of you not familiar with looking at scleral topography, the colors are a little different, right? So we're used to looking at what I look at when I look at this is the red areas are going to be areas of the eye that are physically closer to us. Okay. When you see your deeper colors like your blues, greens, those are physically further away. All right. So I know if I put a spherical chambered lens on this eye, one, it's going to land right where those red areas are. Okay. And then that lens is actually going to kind of decenter down this way. All right. Um,
Down and to the left
so
a little bit, into the
yeah,
blue-green area. Yep.
exactly. And if you have, say, whatever lens you're fitting, if there's hash marks on that, flat meridian, they're going to kind of end up right at like a with the rule alignment. Um, so that's kind of the first thing I see. You can look at a map and know exactly basically what your rotation of your lens is going to be just by looking at it.
Yep. Yeah, one other thing, if I go back and remove these rings, I think when you look at the cornea, this is a pretty solid with the rule cornea,
Mm-hmm.
right? And so someone might say, well, if I put a lens on this eye, this is a with the rule cornea, so how is that going to affect my fit? And the reality is, it's not. It's really not going to affect your fit. What's going to affect your fit is not the cornea. What's going to affect your fit is the internal landing point, or the point at which we transition from vaulting to haptic or landing. And that is the inner purple ring here. That's the
Mm-hmm.
point of interest. And when you look at that inner purple ring, we're already on the sclera. We're already on the sclera. And at that purple ring, the area that's most elevated is more like 10 and 4, not 3 and 9. And so if we put a toric scleral lens on this eye, the lens is going to rotate like 30 degrees to the left. And our flat meridian is going to be sitting around 10 and 4, not with the cornea. So the cornea isn't irrelevant to our fitting process, but we can't let the shape of the cornea itself affect how we think about how we're fitting it. We have to think about that point of landing just past the limits. What's the shape there? What's the shape there, not on the cornea? And again, in this case, it points to the fact that that area of landing, our internal landing point, is actually out on the sclera, not on the cornea, of course, and it's rotated. So that's where our lens is going to position. Again, if we look at a picture like this, you can see as we looked at the horizontal meridian, let's say, it's more elevated.
Mm-hmm.
And if we look at the vertical, it's more farther away from us. It's steeper. It's deeper going away from us. And so if you look at the bottom picture underneath the color map, you're going to see the profile of each of the meridians stacked on top of each other. So the center, they're the same, but as we go out in each meridian, you're going to see that the horizontal meridian, which is the darker colored curve there, and the vertical meridian, which is the paler line, have a separation in their spacing, in their heights, that starts quite early on. And if we look at the internal landing point, which is about that blue line that goes north and south on our grid below, that blue line shows there's a big gap in the height of our horizontal meridian and vertical meridian at our internal landing point. So if we scoot over to the picture on the right, when we put a spherical chambered toric haptic scleral lens on that eye, what happens is we touch nicely at the end of the lens in both meridians, but we have this big gap in the vertical meridian at the internal landing point of our eye. And so this is not a good out. This is not a good way to fit this eye. Using a spherical chambered lens on a highly toric eye is ineffective. We really need to start thinking again about how do I fit the the lens for maximum scleral alignment means that we must get the lens to land down at the point in the same place on the eye 360. Okay, so we're going to talk about that a little bit. So Jamie, do you ever see decentered lenses?
Oh, my lenses are always perfectly centered. No, I'm just-
Yeah. Well, that's what makes
Yes,
you such a
yes.
great fit.
Decentered lenses, I think, that with chamber fogging is probably like the bane of all of our existence, right? So,
Yeah.
especially as soon as you put any diagnostic lens on, is usually going to be decentered.
Yeah.
And one thing that, has really evolved my fitting too is thinking about this. You want to look at your lens in a centered position. Okay.
Mhm.
So I kind of compare it to if you were fitting a corneal gas perm and that lens was decentered. You wouldn't look at that fluorescein pattern in the decentered spot, call the lab, and make changes there. They would tell you to manually center it where you want to and then look at your fluorescein pattern. Right. So, one thing to really look at is when you're assessing a decentered lens, maybe it's your diagnostic lens from your fitting set, just make sure you're actually pushing that lens to a centered position, like in that middle meridian, that middle picture there. And what you'll actually see, if I was just looking at the lens on the left, I would say we have limbal touch superiorly. I would call the lab and say, increase my limbal clearance. I don't want touch there. But if you actually push that lens to the centered position, you're actually going to see that you're overvolting that steep meridian there. And basically, gravity is going to be pulling that down until it hits that area of first contact on the superior conjunctiva. Okay. Um, so in the past, we used to just kind of crank up that, haptic toricity to try to grip and pull that lens up. Uh, but truly, just kind of going back to your roots and putting fluorescein in the bowl of the lens, look at the lens in the centered position, and just kind of zoom out and see what exactly is happening over the limbus.
Yeah.
And if you're not putting fluorescein in your lenses, and I will be honest with you, I stopped doing that for a couple years. You're going to miss a lot of these subtle findings, especially over the limbus. So there's my
Yeah.
my 2 cents on making sure you're putting fluorescein in the bowl, especially when you're fitting diagnostically, because otherwise you're going to miss a lot of your limbal details.
Yeah. Yeah. The problem with the picture on the left, if you just call and say, I will need more limbal clearance, what's going to happen?
Mhm. It's just going to decenter more.
It's just going to de
It's just
what's
it's
going to
just going to
happen is
make
you're
it
going to end up
worse.
with the same look superiorly, but you're going to have more clearance inferiorly where you already have way too much. And
Right.
so a lot of this is, when we try to fix this decentration by steepening the haptic, it's kind of like if you imagine you were hanging off a cliff and you were gripping with just your fingertips.
Right.
Okay, how long are you going to hang there? Versus if I put my whole arms on the top and I'm holding on with both arms, the whole surface of my arms, I've got a lot better chance to hang on there if I got more of my arms in the process rather than just grabbing with my fingertips. So we want to get more of the haptic in contact with the sclera, and then that lens is going to actually stay put better. It's going to stay centered because it's got a lot more surface area to hold on to the superior sclera and conjunctiva so it doesn't slide down as much.
And it'll be a lot more comfortable for your patients too, right?
Definitely,
So
definitely.
like look at this picture here too. This, I'm sure we've all seen this where someone's having midday fogging and you're like, how the heck is it getting in? Because if anything, it
Yeah.
almost looks like it's too steep in this area.
Yep. If
I
you
don't
look
want
at
to
the picture on
steepen
the
my edge
right, it's
anymore.
like you're
Yeah.
touching. So why is
Yeah.
crud getting
Why are
in?
they still getting fogging? Why is it
Yeah.
uncomfortable? What should I do? I don't want to make it steeper. And the answer is we're not just trying to steepen that last little portion of the lens because it's going to cause a lot of long-term discomfort for your patient. Okay. That's going to reduce their wearing time. It's going to, so I think a lot of times we get so worried about we don't want to touch the limbus or, looking at our central clearance, but really it's kind of looking at that whole quadrant. Okay.
Yeah.
Um, so yeah, just kind of zoom out and look at the big picture of what is actually going on while you center that lens.
Yeah. Instead of steepening right here at the edge where it would dig in more, what you want to do is you want to deepen the lens back here,
Mhm.
get it to grab earlier into the process, and then actually you'll flatten the edge to continue the alignment all the way through. So by steepening the edge only, you're actually making it worse.
Hmm.
Ultimately, you've got to get the lens into position closer in, nearly almost, way back toward the limbus, get it to land there, and then align it all the way through. And so this just points out again the fact that when we want to align the sclera, um, we've got an external landing point, which we obviously want that to lay against the sclera beautifully. But in a spherical eye, a spherical chamber, if you will, the spherical corneal limbal zone, like the purple ring would be here, the inner purple ring, that's easy. We can land that thing beautifully. But when we've got a toric eye, and we fit it with a spherical chamber, we're going to end up with a oval-shaped fluorescein pattern like we just saw in our previous examples, and like you would see here with the orange line designates where your fluorescein would extend to if you had a toric eye with a spherical chamber lens. So this is just a graphic that kind of walks through this again, and I think, again, maybe is helpful. If you look at the scleral map in the center of our picture up at the top, you can see that our meridian, which extends from about 2 o'clock down to 8 o'clock, is our more elevated meridian, our shallower meridian. And from 5 to 11 is our deeper meridian of our eye. So if we were to show you what that looked like in cross section, that would be the picture down below. Okay, so the shallower meridian from 2 to 8 is your lighter purple line. And the deeper purple line and is our other meridian, our deeper meridian that extends from 5 to 11. And so if we overlay those, what you see is the difference in those two meridians depths doesn't just occur in the scleral zone. It's not like the cornea limbal chamber is the exact same, and then all of a sudden when you get to the point where you get to a point where the lens lands at the limbus, the scleras separate out in shape. No, that shape difference occurs over the cornea, limbus, and sclera over the whole eye. And so when we fit a lens to that eye that is spherical in shape, we are going to align to the flat meridian nicely. It's going to land internally here where it belongs, and it's going to align to the sclera all the way to the edge of the lens nicely. But we have this big gap then in our steep or deep meridian where debris and misalignment can occur, and that creates all of our issues.
Hmm.
So what we know is we need to then add toricity to our lens. And so again, 10 years ago, we all kind of accepted the fact that, yeah, we need a toric lens a lot more often than we used to do. So now we're going to fit a toric lens. And by toric lens, for most of us, that meant adding toricity to the haptic.
Hmm.
Because we look
Just
at this
changing
map
the
and
angle.
yeah. And so what
Yeah.
happens is we fit a lens then that is toric, and that lens has a steeper haptic, which then brings it into contact with the sclera at the tip of that lens, but it still maintains this gap in the middle because most of the separation between the cornea and the sclera and then the lens has occurred internal to the edge of the lens. And that we haven't done
Hmm.
anything about. And so you get what you see in the picture on the upper right, which is the tip down, the toes touching, but the rest of the foot is up in the air, hanging up above the sclera and conjunctiva.
Hmm.
So what we really want to do, of course, is we want to fully align the haptic, not just the tip of the haptic to the eye. We want to fully align the haptic. And to do that, what we need to do is we need to add depth internally to our lens so that we bring the inner landing point down into contact with the sclera. And then our haptic can align all the way down to the edge of the lens. So we've got full alignment in the shallow meridian and full alignment in the deep meridian. And that gives us a beautiful fluorescein picture like the upper right. And that upper right picture is the same picture we looked at a few slides back where the lens was badly decentered and over vaulting when we centered up our lens. And so just by simply creating a toric chamber for our toric eye, we then create a much more aligned fit where the fluorescein is evenly spaced over the entire ocular surface.
Just keep blinking like
No, I
you.
don't want audio. Sorry.
You don't want to hear yourself talking to your patient
No,
too?
I really don't. Anyway,
No, it's fine. When it
yeah.
actually, when you stand Thank
And
you.
this makes a big
Okay.
difference too, not just for us looking at our beautiful fluorescein images. I will tell you that once I have switched my patients to a better aligned lens, even if they weren't complaining before, they are dramatically happier afterwards. Okay.
Mhm.
I think a lot of times our patients are just happy to be able to see, happy to be able to function, but we can do better.
Yeah.
And that's a really great thing about how much scleral shape data that we have now versus 10 years ago. It's just really helping us to fit our patients even better and better and give them longer wearing time and less complications.
Yeah. And so, Jamie, we just talked about how important it is to understand to land that thing on the inner part rather than out at the edge of the lens. But I don't have a scleral topographer to know that. Like you're looking at all these
Mm-hmm.
beautiful images, and it's obvious from that where I need to land. If I don't have that instrument, can I still fit with chamber toricity to better get a better fit?
For sure. I mean, I just got a profilometer about 2 years ago. So I was doing this for years. It takes a little bit more skill, diagnostic skill of looking at what's going on with your fluorescein. But again, just asking your patient, talking to them, what am I seeing with my slit lamp, but also what are they feeling? Does it feel tight? Does it feel like you're getting a lot of redness, especially after you remove your lens? So
Mhm.
the main things I'm looking for is like movement with the blink, like you saw in that video there. Obviously, for having lens movement with the blink, we know that the lens is not aligning properly with the eye. Look for that decentered position. Look at your fluorescein patterns. Take the lens off the eye and look to see if it really rebounds. Because a lot of times you can't see that compression right away until you take the lens off, and then those blood vessels refill up with blood. So take the lens off the eye and take a look at it all.
Yeah. And I think it's one thing worth noting. So this is just a pearl for everybody to kind of jot down. If you've got a patient in a lens and you're adding toricity or you've added toricity to the haptic, and you're still having issues with like decentration, fogging, lens movement, and you're thinking, I should put some of this toricity in the chamber. Um, a general rule of thumb is 2/3 of the toricity in the whole lens can be inside the chamber and 1/3 in the haptic.
Mm-hmm.
So if you already have a patient in a lens that's got like 250 microns of toricity and it's still not working, and you're like, I really should put some inside the chamber. Well, 2/3 of that's about 160 microns. So you can just
Mm-hmm.
migrate 160 microns of toricity from the haptic into the chamber and then just put 90-ish in the haptic. And then you're going to end
Yep.
up with a much better fit. So again, the things you see, the decentration, the movement and whatnot, all those things are indicating to you that even if it looks like my edges are touching, I don't have a proper fit. And if I'm putting toricity in a lens in excess of, again, about 150 microns, you should always be splitting 2/3 of that into the chamber and 1/3 into the haptic as a rule.
Mm-hmm.
Again, if you have a scleral map, it's going to show you this stuff automatically. You can simply set the ring diameter or the cord diameter that you're looking at the shape of the eye to the internal landing point or the end of the chamber, and it'll tell you how much toricity you should put inside your chamber and how much should be left for the haptic. It's all right there in your diagnostic fitting data in your topography. And so this again is one of the great values of having instrumentation is it will streamline your fitting significantly by telling you exactly how much toricity I should put in the chamber and how much I should put in the haptic. Here's a great example. This eye has 570 microns of toricity. If I put that all in the haptic, the tip will lay down, but the lens is going
Yeah.
to decenter badly. You're going to have all
Right.
sorts of fit issues. And when we look at the internal landing point and see there's 330 microns of that is inside the vault or inside the vaulting
Mm-hmm.
chamber, and we split it 330 internal, 240 in the haptic, we get a much better fitting lens. If I didn't know that by my map, if I didn't have a map, again, that's about 60% of it right there. So it's following pretty close to the 2/3 rule.
Mm-hmm. And we'll go over a little case study here that I had of a patient as well, where I used my maps, but I also used like OCT and just looking at the fluorescein patterns, and that helps out a lot too. So I had a patient, a 72-year-old, who came in with a 40-year-old graft. It was so tilted. He was currently not wearing a lens in that eye. I wasn't able to refract it. It's been a while actually since he had tried to wear a lens because he always had discomfort. There's a picture of just his natural eye there. If you go over to the next slide, I was able to do a profilometry of his eye, and you can see that is a really, really irregular graft. Okay. But the main thing I wanted to do, if you do one more click, you can actually see where a lot of that irregularity is, and it's right around where that vaulting chamber of the lens I was going to be fit is. So that's a huge difference. So about 900 microns
Hmm. Wow.
of difference. Granted, if you look at it, I knew that wasn't going to be perfectly symmetrical. Um, so if you want to pop over to the next slide,
Mhm.
there's also an image here. If you look at the object section on the right, that's actually his graft. There's no lens on the eye, so you can almost see that his graft has like a shell.
Mhm.
And he said he could actually like feel his graft when he was blinking, right? Which is kind of wild. And then looking at his profilometry, I kind of like turned it on its side, and you can see he has like this high point on the graft there. So
Mhm.
obviously in the past, he's probably had a really difficult time wearing a lens. And if I was fitting him in a lens 10 years ago, I would have had a really tough time fitting him as well, just with the capabilities that we had. So what I tried to do first, oh, there's another image too. So even if you don't have profilometry, okay, this was just the deepest lens in my diagnostic set, and you can really kind of see that exact pattern.
Mhm.
Okay. You can see that we're having touch there at the graft. You can see how it's kind of that, the diagonal pattern. So you can read the fluorescein image here, and it lines up perfectly with what my map was. So even if you don't have a map, you can take a look at this and do OCTs over the different quadrants to really see what's going on. So first thing I did for this patient is I wanted to order basically a trial lens essentially because all the lenses in my set were a little bit too shallow. If you pop over to the next slide, I'll show you. Basically, I just wanted a deeper lens. And I started out by putting about 500 microns in the vaulting chamber. I knew I was probably going to need more of like a quad. So I
Mhm.
didn't want to put all 800 immediately in there. So what I basically wanted to do was just get a lens on the eye. That way I could see exactly what was going on and start taking some OCTs over it. So if you look at, here's my OCTs of that first lens. Honestly, not awful. Okay. But we could definitely do better. We had some touch still over that graft, and then the other meridians were really overvolted. Okay. I think, and maybe this is my own personal opinion,
Mhm.
overvolting different areas of the graft are actually more harmful to me than that little bit of touch that we have.
Mhm.
Okay. Especially when that graft is 40 years old. I don't want to create a hypoxic situation. So I got a lens so that way I could just take a look at the rotation of it, really dive into all the different major quadrants and dial it in from there. So what I did was I just took my OCT images and talked to consultation and kind of knocked down those overvolted areas in the different meridians. So the lens I actually ended up at on the next slide, um, there is about 900 microns of difference between the quadrants, but it's not exactly in that nice, horizontal and vertical meridian. So we actually just did a quad seg lens, and the patient was able to see 20/20 and wear the lens all day without having a lot of those like pressure points from overvolted areas and harsh bearings. So for him, it was like a really life-changing lens. And it's great that I was able to use profilometry, but a lot of it was just looking at my fluorescein patterns and
Mhm.
using OCT, which a lot of us have. So you can create a really fancy lens just using what you have in office with OCT. You can kind of see the next slide shows kind of some of my ending OCTs. I didn't do all four quadrants because I didn't know this would be a case study one day, but so the main thing was just trying to get more of an even alignment. It's never going to be perfect. You're not going to have a perfect lens. He had a little tiny bit of feather touch in one tiny quadrant after 6 hours of wear. I was cool with it. He had no staining when I took it off. So overall, a super healthy lens for this patient. It was actually easier for me to fit this eye than his other eye that wasn't so irregular.
Interesting. Yeah, this is a great case, and I think it comes back to the idea of don't forget that you can manipulate the curves and the depths of your lens inside the chamber. And it really doesn't require anything more than talking to consultation and saying, hey, in this meridian, I've got, like you said, 600 microns of clearance. In the other meridian, I've got
Hmm.
zero. And so how
Right,
can I even this out? How can I bring it down in one meridian, up in the other? Well, you can. You can do it.
right.
And so we need to start recognizing that our ability to manipulate the internal curves of our lens will really help us to achieve better outcomes without excessive clearances or inadequate clearances.
Yeah, it would have been really impossible for you to put 900 microns of difference in a quad for free. Like
Yeah.
it just wouldn't have worked,
Yep.
right? So
And I
anyways,
love
there's
I
my little
love
rant.
too in this case, and we could argue about this one. It's beautiful, but the picture on the left where you've got that little bit of touch, um, I'm so much more okay with having a lens have feather touch on a peripheral cornea like that at the outside, not in the visual axis, not on the apex of a cone,
Hmm.
let's say, but on a peripheral cornea, especially on a graft. I find their epithelium, I'm not talking about a new graft, I'm talking about an old one. I find their epithelium to be pretty strong. The graft, obviously, right there is quite thick and sturdy. And having it be very low clearance or almost a feather touch in spots, a lot of my patients tolerate that pretty well, get some more oxygen. And I just don't think it's a horrible thing if you have just a hint of touch, especially out on the periphery like that.
It's funny because actually I made a lens where it was clearing that part of the cornea, and he hated it.
Yeah.
He came back saying, "I'm not wearing this lens. I'm going back to my old one." So some of those things you can just monitor. But yeah, and then looking at fogging, like we said, fogging is kind of the bane of all of our existence. The main thing that you always want to do at every follow-up is what I do is I add fluorescein to the outside of the lens just to really see what's happening. Is there a lot of significant edge lift, like in that third picture, or are you having issues where that lens is aligned and just still being sucked up because you have a vaulting chamber issue there? So looking at, how much fluorescein, how quickly is the fluorescein getting underneath the lens, and kind of nudging the lens as our friend Brooke does to kind of see if the vaulting chamber is aligned. So sometimes you might have to go to a quad specific or freeform lens design if the cornea is really wonky. Um, yeah, and I
Yeah,
think
and I think
Jason's.
if you're getting dye coming under your lens really quickly, again, we talk about tear exchange. Tear exchange is great. We love it on everybody. But if the patient's coming in complaining of fogging, that they
Mhm.
can't wear their lens for more than so long because it gets so cruddy, they have to take it out and rinse it off, put it back in to clear up their vision. And you put in dye and it gets in right away. And if you look and you say, well, my edge looks good there. I don't understand why it's getting in. My lens is laying down against the sclera. You've got to look inside the edge bit and see if are you getting full alignment through the whole haptic or is it just the tip? Because just the tip, when the eye moves back and forth, is not going to keep the dye out.
Mhm.
Last thing to talk about decentration, Jamie.
Yeah,
Talk
so
about that.
looking at decentration too, I think it's important to look at your edges in primary gaze. Actually, last week at ICSC, John Gelly said something really interesting where they've done some studies, and when you're looking around on average throughout your day, most patients actually only change their gaze about 20 degrees.
Mhm.
So if you're having a patient say, look all the way up, look all the way down, look all the way left, look all the way right, you're putting that lens in an unnatural position that it's not going to be in all day. And so sometimes it might give you some false data,
Mhm.
right? Especially if you're just looking at the haptic at an extreme gaze. So try to just have them look slightly left, slightly left, right, up, down. Um, but the main thing is, again, like we talked about, center the lens position. Do not overvolt the limbus because that's actually going to cause a lot more decentration issues.
Mhm.
Is overvolting your limbus.
Yep.
So, kind of
And a
wrapping it
bottom
up,
right.
everything that we've been chatting about. The limbus is the biggest part. I think the most overlooked in general, but trying to
Yeah.
get that limbal area aligned the best as we can.
Yeah, that picture in the bottom right, I think if you look at it up around 10 o'clock, you see some edge lift. You see the lenses decentering down and to the right. And like you said, when I had this patient look down so I could look at the upper part of their lens, looking down, the lens shifted up and it looked beautiful. And so if you had the patient look down and assess the fit on the bottom right, you wouldn't detect that your superior edge was too flat. You wouldn't
Hmm.
detect that because you had the patient look down and it pushed the lens up. That's not normal. You need to look again in primary gaze as much as possible all the time.
Hmm.
All right, so we're going to talk shift then from shape to microvolts. We're going to talk microvolts and HOA optics with our last two topics, our last 15 minutes or so. So, do you want to take this for us, Jamie?
Sure. Well, I think we just have a little mini case actually about microvolts. So if you want to just spin into
Okay,
your
yeah, you're right.
case, and then we'll jump into HOAs to kind of finish it up.
Okay, so microvolts are areas around the edge of the lens or internal of the lens or anywhere where we can accommodate bumps and lumps on the eye. And this is just a case that'll talk through utilization of a microvolt. We have a 65-year-old male with history of RK, wants scleral lenses for better vision. No worries, typical. Here's a scleral topography. What you can see here is a pretty spherical corner or spherical sclera, but with this bump on the internal nasal
Hmm.
aspect. And this is a pinguecula, which is about 260 microns high, using a tool to measure it, but you could estimate that. And here is a picture of the lens, a diagnostic lens on the eye, which is a pretty nice fit overall, just a basic spherical lens, 16 millimeter diameter. But what you do see again is you see this area where our lens is compressing on the pinguecula nasally. And not only is that going to cause issues with redness and compression, it's creating this access above and below it where the lens is lifted away from the eye. That's going to
Hmm.
allow fogging and crud to get under the lens as well. And it's going to make the lens rock back and forth with the blink as well.
Exactly.
So again, here is that pinguecula, and we're going to address that. We could, in theory, we could notch our lens, but that's kind of unpredictable. We're going to do it with a more predictable way, and a way that actually covers up the pinguecula and helps it to be spared from exposure to the outside world. So we're going to put a microvault at the lens edge. What that means is that our pinguecula is probably like so, and our
Hmm.
lens edge kind of comes right through the middle of the pinguecula. If our pinguecula was far more under the lens, or if we were just catching the edge of it, we may put the microvault in a different location. But at this point, we're putting it at the lens edge. So it's right there is where we're at. You can see that from the location of the lens, it's about a little bit below, about axis 350, so about 10 degrees below the horizontal meridian. The peak is at the lens edge. The width of it, the radius of the actual area is 1.5 millimeters with a 1.2 millimeter depth. And then we had measured about 260 off our topography, but a lot of times with pinguecula, I just estimate about 300. What do you usually use as your
Hmm.
starting point? About the same?
250 to 350, depending on how like tall it is.
Yeah.
Um, yeah, and I designed microvaults with just my slit lamp for years. Like you
Mhm.
don't need a profilometer. It's helpful.
Yeah.
You can just use your slit lamp just like you did here with your beam.
Yep, exactly. And so this is the lens then with a microvault put into it. And you can see that you don't even see the area where the pinguecula is. It conforms to it. You see the lens lies down nicely above and below it as well. We don't have that area of edge lift showing up.
Hmm.
And this is, again, a picture of that on eye, rotating the lens off location. You can see the microvault, that little
And
highlighted
then when it locks
area with the
in,
fluorescein, and then it locks
yeah.
in over the pinguecula over time. And to spin it off place again, you can see what it would look like without the microvault, and the microvault then aligning back to that spot. So it really does work great for these type of conditions and should just be utilized anytime. I mean, I put microvaults in probably at least 20% of the time for my scleral
Hmm.
fits, if not more.
Yeah, I do quite a few. I am in Michigan, so we don't have sunlight. For
Yeah,
those of you that are in
in the
sunnier states,
South.
I'm sure there's a ton. But it makes a huge difference
Yeah.
for your patients just with wearability.
And one more
We'll
thing just to
transition.
mention too about microvaults is that now a lot of manufacturers can do more than one. You can do a couple on the
Mhm.
same lens. So that's been a new addition to our arsenal, is having multiple microvaults available.
Well, the last few minutes here, we're going to transition to HOA sclerals, which have been really a game changer, I think, in the industry over the last few years. So, for those of you that are still kind of getting into it, basically what HOAs are, if you go back to your vision science courses, which were a while back for Jason and I, but we know HOAs cause a lot of issues with poor image quality, contrast sensitivity issues, especially with patients with keratoconus and corneectasia, post-LASIK ectasia. Um, so you can see all those E's there on the right, and obviously the patient could read your chart and say that it's an E, but it is not a clear, comfortable E. Okay.
Yeah.
And it's important to note that these are the type of aberrations that we can't just correct with a standard glasses or soft lenses, or even with a traditional scleral lens or even a gas perm lens. Um, there's a really interesting image on the next slide that we go to, where it's, oh, I think maybe it's a couple down, but I mean, some of the main things that you might have for your patients is they talk a lot about halos, right? Starburst, ghosting, smearing, double images. So a lot of times they can read the chart, but there's like five E's, right? It's an E. I see 20/20, but there's five of them. right?
Yep.
Or looking at like a point spread function. I've had patients literally draw out basically coma
Yeah.
when they're drawing out, like, this is what I see when I look at oncoming headlights. And it's really, it can be a huge visual disturbance for patients with these HOAs. And it almost feels like they almost feel crazy.
Yeah.
Like nobody else understands what I mean by it. So finally, we're able to actually correct for a lot of these HOAs.
Yeah.
The next slide will talk a little bit about, why are we still seeing these even though we're wearing a gas perm lens? Like, shouldn't the lens take care of all of these HOAs for us? But it kind of makes sense, especially with things with keratoconus, right? If you have a mild cone, we know that most of their, aberrations are going to come from the back surface of their cornea. So when you put a lens on the eye, it's going to get rid of those aberrations on the front surface of their cornea, but you're still going to have the back surface cornea. And it almost, when you put a lens on, it almost flips their HOAs around, and it can
Yep.
actually make them more visually symptomatic because they're used to seeing a certain blurry. And then when you flip that completely inversely, it drives your patients crazy. So that's why it's always tread cautiously with patients that are 20/25 in glasses keratoconus. When you put a lens on, they might say they see worse. And it's
Yeah.
because you're completely flipping your HOAs for them.
Yeah. So the top picture on the left is a naked eye with keratoconus, and the blue area is their cone. And the bottom picture is the same eye with a scleral lens on. And that same area that was blue in the top picture is now yellow. And that again means they've got coma there, but they've actually
Mm-hmm.
flipped from negative coma to positive coma in that meridian. And so this is all due to, again, to the back of the cornea, because the apex of the back of the cornea, just like the apex of the front of the cornea with keratoconus, is off center, and you do
Mm-hmm.
get the back surface of the cornea has an impact. And so any condition where the back surface of the cornea is decentered, irregular, has got impact, you're going to see HOAs show up. Obviously, we see HOAs with all kinds of eyes, but again, GPs take care of a lot of them if they're strictly anterior surface aberrations. But if they're posterior corneal or lens or internal aberrations, they're going to show up even with a GP lens.
Mm-hmm. So some of the most commonly ones that you're going to see for keratoconus, you're going to get a lot of coma, a lot of secondary astigmatism. I see a lot of spherical aberration as well. For some of your transplants, RK patients, you're going to have your trefoil spherical aberrations. So those are like the most common ones that we're going to see. Some of your post-refractive surgery, they will get that positive spherical aberration as well. So those are kind of your main ones that we're going to be targeting with these HOA scleral lenses. And just really interesting too. I mean, I think we've been talking about HOA sclerals within the industry for a while. And for a while, it was like, does it matter? Do patients really notice a difference or not? There was a really great study that John Gellies did that was presented at GSLS this January. And he actually did a double blinded crossover study where they had a patient fit in an LOA lens or a traditional scleral lens and an HOA lens. And they wore each of the lenses for 2 weeks. And all of the patients actually reported improved distance vision, and most of them actually preferred the HOA optics versus their habitual lenses. And on average, you're going to see about a 56% improvement in those HOA RMS values, or the average aberrations there. It's significant high and low contrast visual acuity compared to their scleral lenses. So I mean, that I love that he did a double blinded study, because for a while it was like, are these really better, or people think it's better just because they paid for a fancy lens, you know?
Yeah.
But I mean, all the patients I fit as well too is, as soon as you put that lens on for them, they can remarkably tell the difference, even if they're seeing the same on the VA chart.
Yeah.
Um,
And you and I have
so
both reported
yeah.
our own experience too. And that 56% is pretty much what we both got to.
Mm-hmm. Yep.
So
We'll go through a
this is
couple
just,
cases real quick with the
yeah.
last like 5 minutes or so that we have. But I think you're first, Jason.
Yep, this is just quick slam dunk kind of case. A 53-year-old female came in who's been in scleral lenses for years, always happy, but the left eye acuity not great, not due to scarring or anything like that, just a more advanced cone with a lot of posterior decentration, a lot of posterior coma. Came in for her annual exam last July, wearing a lens, and you can see the parameters. Real happy, real stable. I just did aberrometry through her lens. You can see ton of vertical coma, no surprise. A lot of vertical secondary astigmatism as well, very typical of keratoconus. We ordered her a lens with markings for HOA application. You can see where the dots are relative to the pupil. The lens is pretty well centered. It's a nice fit lens. That wasn't an issue. And then on the picture on the left, our old aberrometry map, the one on the right with the HOA correcting lens, looks so much more homogeneous and clean in terms of color, and the vision was significantly improved. Here's our before and after maps. The blue, the before, and the orange is our after adding HOA correction. You can see particularly the two bad ones, the vertical coma and vertical secondary astigmatism, we've got almost fully corrected with the new lens. So again, just a perfect example of the kind of patient that really benefits from HOA correction, that keratoconic patient that looks like a clear cornea, but still only achieves, 20, 25, 20, 30, 20, 40 kind of acuity through a well-fit scleral lens.
And then a case I had, corneal ectasia and some scarring after PRK. Unfortunately, my patient had a left eye that did not do well during his PRK, so he was only best corrected to 2200 with his glasses in that eye. He was actually already in a scleral lens, and he could see 2025-ish with that lens. I mean, pretty happy with how it felt, but he was still having a lot of debilitating HOAs. And he actually found me on his own because these patients are out here looking for answers. And if we're not offering them, they will find a provider that is, right? So he actually found his way to me saying, I'm really happy with this lens that I got like 6 months ago, but, can we possibly make my vision any better? So when I did aberrometry, you could definitely see this is pretty typical that, yes, you're having a lot of HOAs. Looking at his topography, yeah, that wasn't a super great outcome after his refractive surgery that he paid for. So yeah, I mean, the main thing is he had a lot of vertical coma. And I think a lot of times when you show a patient this data, it almost makes them say like, okay, I'm not making this up, right? Because otherwise it's like, man, I got him for 2200 to 2025 and this guy is still not happy, right? And it's because of this vertical coma. So he definitely had a high RMS value. So the main things I did, his lens was fit pretty darn well. But I just made a couple adjustments. I wanted to change the haptic a little bit. You could see that he had a little injection when he came in. And I also just changed the base curve to kind of better align with his corneal shape. So it centered the lens a bit better. We had a more even tear film. He actually improved by a line, just kind of getting the lens to center a little bit better over his cornea. But he definitely still needed some HOA correction. So it was interesting that he's like, oh, I already see better just with the first dotted lens I ordered him. He actually had a 33% improvement just by getting the lens centered, which is why it's so important that what we were talking about earlier with having a more centered lens, even on patients that are pretty happy, it's not only going to make the lens fit better, but it'll actually help them to see a little bit better as well. And then he actually ended up seeing 2010 -2, which is crazy. Whenever I do HOA lenses, I really push them just because it's fun if I can get him to see 2010. So his RMS value went down to 0.26. So you can see his aberrometry through his lens. Again, a lot more clean and even coloration there. The main thing for him is like the glare and the halos, especially for nighttime driving. He actually felt like his bad eye was now better than his good eye, of course. And we have a nice little before and after, chart. So
Wow.
perfect. I said, your eye actually is probably better than my eye at this point. So he actually had, quite a bit of improvement, a little bit more than average with putting the HOA optics on. And then I have a little before and after on the next slide. You can kind of see where he started at. The main was the coma. The vertical coma was the main one that we wanted to hit. He had a huge improvement. And this whole process itself, if you look at the dates on it, it only took me a month. From when he walked into my office to when we were walking out with the final lens was only a month's time. That included having a dotted lens sent over to us, taking measurements on it, and then putting the optics on there was only about a month. So a lot of times these things might seem really complicated, but they're not too bad. So kind of wrapping it up, we'll just talk about, how exactly are we going to prescribe these lenses? So the first thing is you want to get your fit optimized first, right? Once you have an optimized fit, working with whatever company that you are partnered with, they'll send you a lens with markings and you're going to scan that through your aberrometer. They're going to make basically they're making a pattern that inverses the HOAs and they're going to send that to your manufacturer and they're just going to put that on the front of the lens. Okay. So you really want a nice stable lens without too much movement or rotation. Make sure that you have all the markings visible on the scan. And then we're going to send that into the manufacturer. So I think a lot of times the patients are nervous, like, I already like how my lens feels. I don't, do I have to start the process over again? And it's really not. It's just once you have your lens, get the dotted lens, apply optics on the front of it. It's not, completely refitting into a different brand as long as your brand is compatible with HOA correcting lenses. So it shouldn't increase your chair time a lot, um, but it's been really significant for improving the quality of life of my patients. And I think it's important that we kind of grasp onto this new technology and offer it to them.
Mhm.
So even though they might seem happy, we could always make things even better.
Yep.
So
Do you get much pushback on the premium cost for them when you have a patient where they're a good candidate?
honestly, not really. A lot of times they say if you think I need it, like I'll go for it. Sometimes they're
Mhm.
not expecting it because I didn't even know the technology existed. And
Mhm.
sometimes I just say, let me grab a brochure and I'll think about it for next year. And I don't have anyone upset that I'm offering it to them. If anything, they're
Mhm.
excited, like, wow, I didn't even know this was an option. And I've
Right.
actually had some patients call back or come to their first follow up and say, hey, I think I want to actually do that upgraded lens if we can do that at the end. And you can always add it at the end of the fit. Um, so I think a lot of it is just with anything that has new technology, it's just kind of presenting it to your patients as an option. I don't
Mhm.
think we should ever prejudge someone and say they don't want to see well because they want to save a couple dollars. You never know where someone is. I would always want to be able to see the best I can, especially if this is a condition I'm living with for the rest of my life. So always just offer it to your patients and then let them make an informed decision. That's all we can really do as doctors.
Great.
So
All right. Well, we've got a little
that'll
time for
wrap it up.
Q&A. Yeah.
Awesome. Thank you guys. So, Jamie, could you answer this question? Because I know that you take some vision care plans.
Mhm.
Are you able to charge OVITs or sorry, the HOA correction separately on top of what the vision care plans cover?
Yeah. So what I do is I have the vision care plan will cover their base lens. And then I have like a separate design fee for the HOAs, and that is kind of like its own code. So I mean that basically covers when you do an HOA lens, you have your extra fee that you'll pay the manufacturer to make the lens. Okay, but then also have an extra fee that you pay. Um, for example, who I use is Ovitz, but there's other companies they charge a design fee. So that's kind of I put that as its own separate code of a HOA design fee, and I just pay have patients pay that upgraded price for that. So I do coordinate their benefits, I guess, the best that you can. If you do want to put it all through insurance, you could. It would just really definitely eat into your profits quite a bit. So something to keep in the back of your mind there. You could push the whole lens through, but I think it would end up making it so you break even, which is not, what we can do as a business of optometry. So I just have that as like a design fee is the way that I do it.
Right. And could you give us just kind of like a range of what HOA correction would cost, like your cost, not your fees, but just kind of like a range of the
Oh,
design
well, like
fee
it,
as well as. Mhm.
yeah. So I think it depends. Each manufacturer has their own pricing. From what I've seen, is usually the manufacturer will charge you anywhere between 125 to 175 extra per lens, and then your design fee is about equal to that as well. So you're looking at maybe an extra like $300 ish, give or take what manufacturer that you use per lens.
Mhm.
So you have
Couple
to
hundred
kind of take
dollars
that
though.
into account. What was that?
Couple $100.
Couple $100.
Yeah.
It's not like going to be $1,000 more. So it's a couple $100 extra. It's kind of like when you add a multifocal optics to a scleral lens as well. Like it is going to be an upcharge because it is kind of more of an optional thing with a multifocal. But
Yeah.
yeah, a couple $100.
Okay, great. And then I'll give this one to you, Jason. Have you ever had a film that's appeared on a scleral contact lens that may be from like a new solution use? They've specifically said the new clear care solution on hydropeg coated lenses and it not come off with Boston Advance cleaner afterwards.
Uh, I mean, okay, so there's definitely a small percentage of scleral lens wearers who have got very difficult lens surface issues, non-wetting issues. And it's a big struggle for some of these patients. You try everything. I would say this, that when I've got somebody who's got some issues with like a film, and I guess we're talking front surface film or back surface film, I don't know which one. Um, if you got hydropeg coated lenses, you've got to be careful with what you use on it for one thing. Okay. So if you're in a hydropeg coated lens and you've got a film, you're kind of stuck. You either can just use what it's approved or you're going to strip all the hydropeg off it one way or the other.
Hmm.
If you're gonna try to follow what they recommend, you're gonna just have to try your best to make do with what's available, which are the approved solutions for a hydropeg coated lens. If you go beyond that, again, if you say, well, that's not doing it, I've still got a film and I've tried everything that it's approved. I don't know what to say then. You've got to then just say, forget the HydroPeg, and we're just going to try to go with the cleanest lens we can get. And then you're going to
Hmm.
talk about using stronger cleaners. You're going to talk about using, a lot of times for me, I will have patients use a cotton tip applicator to clean the back surface of their lenses because your finger just can't quite get in there in the back of that lens very well. So use a Q-tip with some cleaner on it to clean the back. If it's a front surface issue, again, you've got to try to figure out why. Usually these are dry eye patients. And it could be that, you're not lubricating the lens. So like you say, if you use Clear Care, well, guess what? There's nothing in Clear Care that's very lubricating. It's basically a saline type of solution. It's peroxide neutralized. So why would you expect that that would give the surface of the lens a good lubrication? So rub the lens with something. And if you say, well, I don't want to use a cleaner, I don't want to use like advanced conditioner, then rub an artificial tear on it. I don't care. Rub something lubricating though on the surface of your lens and rub it for a long time. Rub it for 30 seconds with a lubricating agent before you put it on your plunger, which by the way, you should put a lubricant on your plunger too, because the rubber of your plunger doesn't do any favor to the wettability of your lens surface. And then when you fill it, again, just fill it with saline, but maybe add lubricant to the back too, and just try to be as lubricating as you can, and then just educate the patient. Hey, don't forget to blink. If your lens is getting buildup or crud on the surface, it's not because they don't know how to clean it. It's because they're not blinking. That's why.
I love the tip on the plunger. I feel like every time I hear you speak, I learn something new. That's great. Were you going to say something, Jamie?
I will say that with the Hydroglide thing, I've had some patients have an issue with Hydroglide where it puts a film on it, and I just haven't put it through original Clear Care and it takes it off, in my personal experience. I've had probably a handful of patients have a reaction, like an allergic reaction to Hydroglide for whatever reason. And then if I just have them rerun their lenses back through original Clear Care, it works. So don't think that like you have to completely trash that lens because they used the wrong solution once. It should come off.
Yeah.
So yeah.
And this will probably be our last question before we take our 10-minute break. Um, but in regards, Jamie, you had that case where you looked at base curve changes to better align with the cornea.
Mhm.
Do you ever make base curve changes to help with HOAs?
Um, More just to align to the cornea. I'm not making them specifically with HOAs in mind.
Mhm.
I just
Mhm.
find that if the lens is centered better and you have a more aligned tear film, it won't induce as many HOAs because you have your HOAs from your cornea, but sometimes we induce HOAs by having a decentered lens, right? And like a prism essentially in our tear film reservoir. So if I'm more so just trying to align the lens better. That way I'm not inducing extra HOAs that shouldn't be there. Does that make sense?
And
Mhm.
I think the
For sure.
only effect on HOAs that you will have by changing base curve is going to be spherical aberrations.
Hmm.
Again, the other aspects of it are going to be more related to centration, like Jamie said. Yeah, if you
Hmm.
center a lens better, you can get rid of some, but strictly base curve change alone, if it doesn't impact
Hmm.
the fit in terms of how it centers, if you're talking just strictly base curve change alone, it's only going to be helping with spherical aberrations. And here's the reality is remember a scleral lens, any GP lens for that matter, is not just the lens, it's the tear layer and the lens. It's a system in combination. So as I flatten
Hmm.
or steepen the base curve, my tear layer underneath it flattens or steepens oppositely. And ultimately, I am left with the same optical system no matter what my base curve is. If I flatten my base curve of my lens a lot, I'm going to then be increasing the thickness of my tear layer in the periphery as well. And so ultimately, I'm left with the same essential functional surface underneath the lens because the patient needs a refracting surface no matter what. They need a
Mhm.
specific prescription. So as I change the prescription of my lens, I change the base curve, the tear layer, and everything as a system. The impact is pretty small. And so I'm with Jamie. I wouldn't do that for that purpose. I'd say it's such a small yield compared to what you can get by doing customized HOA correction.
Mhm.
But if you've ever had those patients where they are insistent that they see better out of one lens versus another when you have no HOAs, it's probably
Mhm.
because the lens is not centered. Like something, it's
Yep.
not necessarily base curve, it's something with your fit,
Mhm.
right?
Right.
So just kind of go back to your basics because I've had patients say that and it's confusing to me. It's like, well, you see the same on the VA chart, but you're insistent that like the last iteration of this lens you see better. You know,
Mhm.
it's like what the heck, what's going on? It's something with your fit is off.
Yep.
Mhm. Okay, just one more. We have just one more come in, and then we'll do our break. Dr. Kuzner, this doctor said, I also have the eaglet. Are you sending the scans directly to the lab without adjustment and letting the lab design, or are you being more specific with what you want for that particular fit?
I like to have control over my fits. Maybe I have a control problem, but sometimes I'll direct connect the map to consultation. That way they have it. I also just know that sometimes my scans are awesome. Sometimes I know my scans are not awesome, depending on the patient tear film, how I took it. So I don't have the lab directly, go off of my scan, especially in those situations where I know it's a not super great map, but at least I got something on the patient. So I kind of use that to design on my own because I look diagnostically and I look at my map and I kind of make a hybrid of what I want to order.
Mhm.
So I'm not letting the map do 100% of the lens for me at this point.
All right. I like that. Potential control problems. Cool. All right, guys. Well, thank you so much. We'll go ahead and get you guys a break for about 10 minutes, and then we will be back on 20 after. All right, welcome back, guys. It's great to see you, Dr. Messer and Dr. Holland. Then Dr. Jedlicka is going to be rejoining us today. So now we get to hear a little bit about HOA correction in action with Zenlens Chroma HOA.
Take it away.
Yeah, go ahead and take it away from here.
All right. Hey, Zach, good to see you.
Morning.
Um, for those of you who are, kind of new to the scleral lens world and maybe don't know all of us on your screen today, Jason, Zach, and myself have a fun history together. Jason started the Cornea and Contact Lens Institute back in 2009, and then when I finished my residency, I joined up with him after that. And we practiced together for just about 5 years. And then that's when he pursued his interest in academia. And around the same time, right after Jason left, Zach rotated through our clinic as a student and then later came on as an associate at the practice. And then when I decided to pursue my next phase of my career, Zach took over the practice. So at any given time, one of us has owned the current practice that Zach continues to lead. And so it's fun to be able to kind of have conversations with these two for me because I have, Jason as a mentor and then watching Zach, come, and succeed with the practice. And so hopefully you get that out of this presentation where there's just a lot of, both like mutual approaches to fitting lenses, but also we have our own techniques too, because we've each had our own experiences, together and independently. So with that, we're going to go ahead and talk about Zenlens Chroma. And we're going to talk about the HOA correction that's now available on the Zenlens. Oops, there we go. And as I just mentioned, Jason, we've heard that you're at Indiana with speaking with Jamie. And then Zach, will you just give a quick introduction about yourself?
Yeah, you
If you
did a
want to
pretty
add
good job.
anything. Okay.
Yeah, I'm in Minnesota at the Cornea Contact Lens Institute in Minnesota, and we primarily focus on specialty contact lens fitting, so kind of a referral source in the area. And like I said, Brooke was my previous mentor, so and an existing mentor.
Mhm.
But then yeah, Jason have some experience, and interestingly, the patients in the practice have seen actually all three of us, so it's
Mhm.
kind of an interesting link.
Yeah, it's fun. And here are our disclosures. So today we're going to chat. I'm going to lead the discussion and prompt these guys with some questions about identifying higher order aberrations in our patients, how we, optimize the fit to make sure we can take advantage of the, awesome technology that is in higher order aberration correction. Jason, I know you and Jamie just wrapped up talking about that, and then we'll show some patient examples. Most of us know or learned what higher order aberrations were at some point in our academic education. For those of us kind of deep into scleral lenses right now, it's at the top of our mind when we're looking at many of our patients. And for those of you who are maybe new to scleral lenses, we learned about it back in school. So it's the fancy words like trefoil, quadrifoil, coma, things like that. And these are basically just imperfections in the way that light travels through our visual system to create residual blur, glare, halos, and things like that. And even with a GP lens on, our patients with keratoconus and other irregular corneas still have some of those imperfections that travel through the scleral lens. GP optics do a pretty darn good job of reducing a lot of that higher order aberration, but sometimes some still persist. And, these are the patient complaints that you'll hear of. They talk about haloing, starbursting, ghosting. We have coma listed there, but a lot of the times patients say there's like a tail coming off of it. There's a streak coming off of it. And of course, some double vision from irregular astigmatism. And so these are quite common symptoms that our patients will complain about. And again, because scleral lenses do a pretty good job of neutralizing those things up until, the last couple years when HOAs have really, hit the kind of mainstream scleral lens practices, patients have just had to kind of deal with good enough. We did the best we could with a good fit. But now thankfully we can actually measure and then correct those types of aberrations. And so the most common ones you're going to see are keratoconus. Our patients with keratoconus will have coma and secondary astigmatism. Corneal transplants and RK. We'll see a lot of trefoil and spherical aberration. And then with our patients with refractive surgery, they tend to have that positive spherical aberration as well. When I'm doing my measurements, I also see my KC patients tend to have a bit of spherical aberration. Do you guys agree too?
Yeah, especially the younger ones. I mean, the younger patients definitely have more, their pupils are bigger and whatnot. I think there's definitely a good bit of our patients with spherical aberrations for sure.
If the patient is accommodating in the aberrometer, does that make a difference in their HOAs or not? Do we know?
I mean, it can a little bit. It can affect pupil size, things like that. For example, it probably can affect things slightly because it's going to change the lens shape internally. I would think it's a pretty insignificant amount because we all do it all the time, and then otherwise it would degrade our vision when we did.
Sure.
But again, as we try to really nail someone's HOAs with a lens, it's a good thing to bring up in that like we don't put an HOA correcting lens on someone's eye and see their RMS go from 1.1 to 0.00. We don't get it like that, you know. So what we're even in a normal eye are we have HOAs of a certain extent. So we can't go for perfection. And things just like that. Maybe, for all we know, accommodation affects your HOAs by zero point 0.0 something, and so whether it's in the act of doing it or whether you're measuring it and trying to correct it, it's possible it changes it a very small amount. Yeah.
When we're talking about measuring wavefront aberrations, we have this value called the root mean square or the RMS value, and this basically describes the way that the HOAs interact with each other. So when a patient has coma and trefoil or spherical aberration and secondary astigmatism, there are the different aberrations impact vision in different ways. Some are more visually impactful than others, and so they have kind of a higher weight on our vision quality. And so again, the RMS value basically helps us kind of quantify the magnitude of the visual disruption that these aberrations have on our vision quality. And you can see that somewhat complicated appearing formula there. Thankfully, that's not something we have to calculate on our own. The instrumentation that's available for us now through various instruments are able to calculate that for us. And so when we do a scan and we get a graph pattern like this, it'll just spit out the RMS value. And Zach, when you're looking at these aberration values, can you tell me what's significant to you? When would you approach a patient on this is enough to make it worth the investment?
Well, I think it depends on the patient's visual acuity. If they have a high level of acuity, but they have high RMS, maybe that's not something that you have a high level of talking with them. I mean, a lot of patients can benefit from HOA lenses, even if they do have high quality acuity. But I think once we get to like the point 0.4, point 0.5 level is when we can start seeing a quantifiable increase in some value because these patients, remember, they're paying for an upgrade. And so from a practitioner standpoint, we have to justify that and give them something in return. You could fit an HOA lens on every single patient and some would improve more than others. But there's a time and a cost association with these things. So generally, I'm looking at zero point 0.4, zero point 0.5, but a lot of patients like this one has almost a zero point 0.8, and so they would probably see a higher level of improvement.
And Jason, when you look at RMS values, how do you talk to patients about, hey, this is the kind of vision that you're going to get? It's hard to say that you're going to get great vision. It's challenging, right?
Yeah.
But how do you say do you say you're going to get X improvement? Do you describe like quality, lines of acuity? How do you
Yeah.
explain it
I
to
think
the
it depends upon the aberrations. Again, we're going to look at some other cases before we're done here. As you look at this patient, an RMS value of 0.75 is high enough that they should definitely benefit from HOA correction. And again, it depends, like Zach's saying, if the patient's 20/20 and they have an RMS value of 0.75, you're going to describe what you're going to notice. The improvement is going to be in the quality of your vision. You're not necessarily going to read more letters on the chart, but they're going to be cleaner. There's going to be less, you know, less ghosting, less doubling, less glare. If you've got a patient who's 20/30 acuity and they've got an RMS value 0.75, I definitely am going to tell them they're going to see the chart better when we're done. But in this case, the one thing I would love to take home off of this example is that none of those bars, and you see several bars that are up in the zero point 0.2 to zero point 0.3 range, your vertical coma, horizontal coma, trefoil, spherical aberration, so on. But none of them independently are up in the severe area. So you've got this cumulative effect of several different aberrations causing this RMS value. This one's going to be a little harder for me to sell on the idea that they're going to notice a lot of improvement, as if one or two of the aberrations were way up in the severe and the rest of them were normal. I think you get more of a noticeable improvement when you can take an aberration value from severe down to next to nothing. And this is a case where you've got, again, one that really stands out above the rest. This one, it might be easier, even though the RMS value is a little bit lower, they might actually notice a bigger improvement because you're going to really, you're for sure going to get that one aberration that's up at the severe level noticeably improved.
Yeah, I would agree. It's pretty impressive on how they can really hone in on that part, that correction, in the optic of the lens to reduce that main player in their vision quality. And I agree with you, Zach, that, the scattered one that we had on the previous slide probably is still going to notice some improvement in their quality, but this patient may actually get lines of acuity, 1 to 2 lines, sometimes more than that, of acuity improvement by correcting their HOAs in the lens. And so let's move into talking about, how do we prep the eye? How do we prep the lens for good success with HOA correction? And that's basically lens stability. Just like a front toric lens, if it's spinning around all over the place, it's harder to have an accurate over-refraction and correctable, cross-cylinder math and all of that, adding it into the lens to get a predictable vision improvement. And it's even more important with HOA corrected scleral lenses where we really need to have that lens sit in the same spot every time. So how do we kind of approach stability and, when it comes to correcting the HOA correction? Zach, do you make sure the lens is perfect first? Do you add in the HOA alongside? How do you separate out that process of the fit and then talking about HOAs and then adding the HOAs in?
Yeah, HOAs are interesting in it's almost a two-part process that you have to fit the lens in. Where when you're fitting the original Zen lens, you can adjust the power and the toric alignment curve or the bielevation at the same time. Where when you want to add HOA correcting optics, you really need to dial in and solidify the toric alignment curve, whether it's a bielevation or not, just to make sure that the lens is not rotating at all. It needs to be hyper stable. So it's really a two-part process. I often tell the patients like, okay, are we finalized with the fit? Is your fogging complete? Like, are you happy with the comfort? And we're drawing a line in the sand here. We can't regress and go backwards once we pass this line and start dialing in the optics. And just making that hyper clear has been successful in my practice in minimizing patient comfort complaints when we implement the HOA optics.
Yep. I agree. I kind of like that term, the line in the sand, where, hey, like this is a door closing on the fit aspect of it, and then we're moving into the optics. So you really have to have that kind of dialed in to move forward. Doesn't mean you can't talk about HOA optics or even talk about it earlier so that they know it's coming. But it's nice to be able to have that, we need to have that stability first.
Mhm.
Jason, what you
Yeah, I
got?
was going to say one thing that I'll do, like in hopefully, so in a perfect situation, you've got a lens, you're fit, and you feel like you're done, and you're ready to order their HOA marked lens so you can do the scans and everything. So it's like the last of your fits before you start in the HOA process. I always take that lens when it's on eye and rotate that thing in the chair and see how quickly it snaps back into the location it was just in. If it takes very long for that lens to rotate back to where it was before I spun it, then I get a little nervous that maybe we're not done with the fit as much as I thought we were, that I need that thing to be extremely rotationally stable. We were talking at ICSC last week 6 degrees is the tolerance basically for HOA correction of rotation. So if that lens is rotating more than 6 degrees of variance one way or the other during wear, the HOA correction is going to suffer for it. So again, I'll take that lens, spin it on the patient's eye by like 45 degrees, and then just watch it and see if it spins right back. If it goes right back within a matter of seconds or even a half a minute, I'm good with that. If it takes several minutes or labors to get back at all, then I'm thinking, do I need to increase the toricity in this lens a little bit more to get it to go faster?
Do you guys measure rotation in the lens with just your slit lamp beam, or do you do something more precise?
Slit lamp beam.
So I use my slit lamp beam if I'm measuring for toric alignment curve, but I have a slit lamp camera that um, I can draw on the image and it will give me the exact rotation of the lens, which is kind of neat. But I really only use that for when I'm implementing HOA optics.
That's nice. I think that's a good tip too. We have a topographer that has a kind of the axis dial around it. And so sometimes my technicians will grab an image of that too, just so that we can kind of see over time if that lens is moving at all. So that's kind of a nice way to do it. But most of the time I agree with you, Jason. I just do the slit lamp. Okay, we're going to just continue to talk about stability of the fit and just a brief little tangent to talk about bielevation. And Jason, I think when you started working on this bielevation technology, and it's probably been one of the most impactful things on a well-fit Zen lens, in my opinion, since the beginning. It just solves so many problems, whether it's chamber fogging, conjunctival prolapse, lens decentering. We've even noticed through some of our testing with the HOA lenses that, diagnostic lens, a well-fit diagnostic lens has HOAs of X. And then we get that bielevation in there and center up the lens a little better. We actually see a reduction
Yeah.
in
Jamie
HOA.
just had a case in our last talk we did where she did that exact same thing where the patient came in wearing a lens, was generally happy. She tweaked the base curve and a few other things and got the lens to center a little better. And his RMS went down by like 30% just from centering the lens better.
Yep. And then, we continue to kind of hit the home run with the HOA optics. And so bielevation is very impactful in just lens success in general. And a good description of bielevation is what you see that we have written here. Previously when we talk about aligning that lens to the ocular surface, we're using the dark purple or those outermost curves in the APS of the Zen lens or the haptic. And so we're really dealing with flattening the edge or tightening the edge. But it never really addresses the landing point. It just changes the relationship of the very edge of the lens to the ocular surface, or what we call the toe of the lens, where bielevation actually bends the lens right at the edge of the, closer to the end of the optic zone. And it brings the lens closer to the eye, or further away if it needed to be, but it brings that lens in closer in the right spot so that we reduce that mid-peripheral clearance and allow that entire haptic to land on the ocular surface so that we can, optimally center and utilize that entire landing area to kind of bear the weight of that entire system, which just improves patient comfort, again, optics, all of the things, just a really great technology in optimizing this fit and prepping these eyes for HOA correction. When you see the bielevation on a Zen lens parameter sheet, you would see it described as a dual sag lens or two sags. So you'll have a deep sag and a shallow sag because we have a shallow sag for the usually the horizontal meridian of the eye. And then the deeper sag is the part of the eye that's further away from us in the slit lamp. And that part of the lens is deeper, reaches further away from us to the ocular surface so that that chamber and landing curves can be properly centered all the way around. Coma, trefoil, spherical aberration, by far going to be the most common aberrations that we're working with, but thankfully we can correct all of the aberrations that you see on the scans, whether you're using the OVITs like many of our cases are. There are other devices out there that are working well to add HOA correction in there, but these are going to be kind of the heaviest hitters in improving optical quality. All right. So who wants to take it and tell us how HOA correction works in a scleral lens? You want to do it,
Maybe
Jason?
I can do it
Zach,
simply,
go
and
for
then
it.
Jason will go into the details. I mean, if you think of like noise canceling headphones, it works like that. And so the lens is, once you implement the HOA optics in the lens, it's implementing equal and opposite magnitude of aberrations to cancel out those distortions, whether they're coming from the posterior cornea or internal astigmatism on the lens. Um, I don't know, you want to explain that better, Jason?
No, that's exactly right. I mean, you're just negating the irregularities of the ocular surface with the opposite so that it's creating an even pattern and pulling all those points of light to a single focus point instead of that scatter like you see in the diagram there.
Yeah, we were recently all together at the ICSC meeting. It was just last weekend, and Katie Morrison calls it glare correction, which I think is a really nice way that patients can kind of grab onto that description and understand that, okay, my power and astigmatism are in my lens, and then I have this extra optical correction that corrects my glare or those imperfections in the way that light travels through the eye. And it's just again, a really amazing technology that for me, I think one of the real practice savers or time savers, I should say, is, sometimes toward the end of the fit, the fit is good, the patient comfort is good, but they kind of teeter-totter back and forth on a half diopter of astigmatism, half diopter of power here and there. And now I just stop. As soon as the lens fit is good, to be honest, I'm not really trying that hard on their over refraction because I know that those types of soft endpoints are going to be captured by HOA correction. And I don't do a really, really like detail oriented, fine tuned over refraction until we get that first lens with the HOA optics in it. Because a lot of the times patients are taking more or less power to neutralize their aberrations the best they can. And then once we get the aberration in there, they will have a little over refraction to kind of fine tune what they had previously taken, too much or too little of something in their lens. And so it really has, in my opinion, kind of streamlined the finalization of the fit, which has been a really nice add to, a busy day of practice. Here is some poster data from our good friend Jamie that we just listened to earlier. And she did a study on Zen lens wearers who had chroma added to their lenses. And patients had a mean improvement of 57% reduction in their RMS values. And that is consistent with a paper that was just released by John Gellies and company on visual improvement with wavefront guided lenses. And again, all three patients, all six eyes, reported an improvement in their vision quality. So all of them preferred their HOA lenses to their non-HOA lenses because they had roughly a 60% improvement in their RMS values, which is also consistent with the paper. All of the patients in the Gellies paper also reported that their lenses with HOA correction were better than without their lenses. So that's great data. Just again, as a provider moving into, hey, should I get, these devices? Should I kick it off with my Zen lens? Should I get the Ovits? These are just good values to kind of endorse the success that other providers are having when using the combination of these two technologies. All right, I think we got some cases coming up. Here we are.
I was going to say, Brooke, too. I presented a poster or a paper at BCLA a few weeks ago, too, about my findings with my first 17 eyes. And it's remarkable because I think John's paper showed a 56%, Jamie's was 57. I think mine was 60 on right eyes and 61 on lefts. I mean, it's really consistent. It's right around 60% across the board on everything I've read about these. So it's pretty reliable, pretty consistent. Yeah.
Yeah, and when we're looking at, the endpoint HOA, certainly when we get to that point 0.2, point 0.3, even some point 0.4 values, patients are seeing really well. So we don't have to shoot for, like you said, that point 0.1 or the point 0 something. Again, like when we can get to that point 0.3-ish value, that's consistent with a normal eye. That's how we see those of us without KC. And so again, it's really nice to be able to see that improvement. And sometimes we can even, do a second adjustment on a lens if needed to. You can do a second HOA, addition or assessment to adjust the values. But in general, it's a pretty fun process. Again, implementation of the lens in your practice, you're going to optimize the fit. You're going to capture the aberrometry data. And then the lens is going to come to your office. You'll do a quick over refraction and then add that in if needed. So all in all, it's a very worthwhile process. Zach, can you tell us about what this is?
Yeah, these are the reference marks that you'll see on the patient's lens. So from the provider side, so if you notice, there are some locations that have double dots in a lens that has zero rotation. Those are going to be up and to the left, both on the right and left eye. So the right eye, they'll be up superior temporal, and the left eye, they'll be up superior nasal. But you can also reference the single black dot inferiorly or double black dot for the left eye. Now in your lens, these are all going to be black. So our diagram here has them slate purple and black, but they'll be all black. And so you just kind of have to orient yourself. You can also use the flat markers or the lens engravings to kind of orient where you're at. But this is what you'll see on the patient's eye. The patient won't be able to see these through their vision, and likely their partner or coworkers aren't going to see this on the eye. But remember, this is kind of, if you will, an intermediate or a training lens. So the lens that the patient receives in at the final piece is not going to have any of these reference dots on it, just kind of a single one on the right and two on the left. And so we know if you get a lens like this, there isn't actually HOA correction in the lens. And so practice tip, when I'm finalize the fit and we need to order the HOA reference marks, you're going to tell the patient, hey, we're going to get these reference marks. You aren't actually going to see any better with this on. Not until we scan over this lens will we obtain the HOA optics on the lens.
So what if my dot is 10 degrees to the right or 10 degrees to the left? Does that mean I have to go back and adjust anything, or does the dot have to be at 6 o'clock?
No, it
If you
just
have
has to be in the same
stability,
place. Yeah, it just has to be in the same place every time.
Okay, that's what I was getting at. Thank you.
Yeah.
Yeah, the on a image in a perfect world, 12 and 9 o'clock in our point of view, but it's just a reference point. The lens can be seated however it sits as long as it's consistent. Again, so we'll place that lens on eye, making sure that the dots are in the inferior half of the front of the eye. And then we'll, usually when patients come in with the reference lens on, we try and have them pick it up or mail it to them ahead of time so that they can have the lens on for several hours before they come in for their appointment. So when they show up, we'll quickly check to make sure that all the markers are in the right place, that, the dot is in the inferior half and that the lenses are on the right eye and that kind of thing. So just very quickly ensure that the lens is fitting well, and then we go ahead and scan them.
Just don't have the patients clean their lens with unique pH in the interim.
Yes,
And we'll take the dots off.
yes, if you are a unique pH user in your practice, want to stay away from that because the dots do come off pretty quickly with that one. So just a good practice tip to keep in mind. Those dots can be redotted, but they're never quite as perfect and clean as they are as when they come from the lab. So let's talk about some cases. Zach, will you kick us off?
sure. Yeah, this is a 57-year-old Hispanic female that Brooke and Jason both saw, but this is a similar case probably to Jamie's from a timeline standpoint. So very happy Zen lens wear for probably at least 10 years. She was 20/20 in the right eye and 20/30 in the left, had some other comorbidities, but she does have keratoconus. If I remember right, she's a pretty high myope. Next slide.
Sorry about that.
There you go. Here are her existing lens parameters. For those of you that are familiar with the Zen lens invoices, that's what she was currently in. So she wasn't a microvault in both eyes. And my lens observations are over on the left eye. So nothing specific. She's a plano over refraction. And at the beginning, I don't do this anymore, but the beginning of our HOA journey, I was just interested scanning patients naked eye without a lens. And so we did scan her with her lens, but to be in somewhat of a atypical order here, I have her naked eye aberrations. And so she's pretty worse aberrations in her right eye. And then her manifest refraction was there, 20/20. I'm sorry, jump back to real quick. What was her best corrected? 30 in the right eye and 40 in the left from her manifest refractive error, best corrected acuity. Here's her topography imaging or sorry, tomography imaging. And if you notice the bottom right image on both the right and left, that's going to be her posterior elevation irregularity. And that's where a large amount of aberrations are going to come from. And so if you don't have an aberrometer and you want to estimate, does this patient have aberrations or are they high aberrations? Or if they do have this irregularity on the posterior cornea, likely that's where a lot of the aberrations are going to come from. So here, similar to the posterior aberration maps on your tomographer.
Yeah, so this highlights those. This is just the line of sight through the pupil and those
Mhm.
imperfections and variations of the wavefront in microns.
Exactly. These, I believe, were her naked eye
Yep.
aberrations. Yes, yep. And so we're missing some. I've kind of found that if the aberrations are so high, they're really difficult to measure. And so, again, this is part of the reason why I don't do the naked eye measurements anymore. But just for your own reference, some high aberrations here. Now, in this case, she was fitting fairly well with her lens and was really happy. We just wanted to improve her acuity. And so I just ordered the dotted lens for my first fit. Here it is on eye. These are lenses that are dots that have started to worn off. So if you can see the dots are wearing off a little bit. This is the scan over her lower aberration Zen lens. And so again, really large single aberrations, vertical coma. But she was getting 20/20 and 20/25 out of these lenses. And then we incorporated her HOAs in. So now we have the Zenlens Chroma on the front surface of her eye, and the RMS value has dropped. Her acuity in the left eye was sitting at 20/25 plus, but she quantified a significant increase in her acuity. So this is one where subjectively she felt much better. Quantitatively, we didn't measure as much on the eye chart though. But we did improve. Here's the difference map. So the blue is her LOA lens, the with the Zen lens, the orange is the Chroma HOA lens. So much better.
This is a nice one.
Yep, point spreads here. So this improved specifically on the right eye there. If you can notice, again, ignore the far left image. That's the naked eye image.
Jason, I think this is you.
Yeah, so this is just a similar patient in that she's got keratoconus, 72-year-old female, been in Zenlens in both eyes since 2018, came in July of 24 for her annual checkup, doing well overall, but again, a little bit reduced in the right eye, 20/40, best corrected, and obviously would love to see better, but in the past really didn't have any way to do that. Current lens parameters you can see as are noted there. She's in a pretty toric lens, so 9 steps of Tricity, 270 microns, and a fairly highly minus lens as well. And here's her plot. You can see again the vertical coma is well above the severe line. Everything else is much lower. And so again, as you look at the scale, just keep in mind that even some of those bars that are up there a little bit, they're still at the 0.2 to 0.3 level. They're still pretty low. In this case, again, we've got one that is significant at about zero point 0.9 alone. That's the vertical coma. And this one is one where I would feel really comfortable moving them forward with an HOA lens and being able to just about guarantee that they're going to notice a noticeable improvement. Here is a snapshot of the lens on eye. You can see it's rotated about 10 degrees to the right. All the dots are pretty visible, and the lens does center pretty well on her eye in terms of both, laterally and vertically as well.
Yeah, that looks really nice.
Picture on the left was before with her 20/40 lens. Picture on the right is with the chroma. She's 20/25 plus 2. Her RMS dropped by about 55-60% again from 112 to 0.51. And again, really got rid of that big spot of coma, and that's made the big difference. Here is her before and after point spread function. You can see the picture on the left and the picture on the right, quite a lot of difference. And if you're looking at the Scleral ratio there, the black with the little white smear on it on the left compared to the one on the right is much more discrete. And here's her before and after plots. Again, that the biggest thing is that vertical coma, bringing it down from about 0.9 to 0.3. Really big difference in her in her coma. Really made the biggest impact on her vision.
Very nice. Um, I will wrap it up here and then we should have a minute or two for questions. And so if you do have any questions, you can put them in the chat box. That'd be great. And then we'll address them right after this. I had an 80-year-old male. He had mild KC in both eyes and was, again, mostly happy in Zen lens, had some little bit of issues driving at night. And I was, even though he's 80, his macula looked pretty good. And again, when you look at his posterior floats compared to the two of yours, it's not that bad. And so I was like, why is he only 20/30? And this was right around the time that we got the ovits. So it was really fun to be able to kind of introduce this to him, right as we were working through it. He never really had to settle for, just okay vision. So we ran him through, we got the dotted lenses from the lab and ran him through. And we had some decent aberrations here, noted as severe in the right eye and, kind of moderate to severe in the left eye. And here's our wavefront pattern. We had an RMS value of 1.2 and 0.7, respectively, in the right and left eyes. And anytime somebody's over 1.0, I'm feeling pretty good about, yep, like we're definitely going to get some vision improvement in this patient's quality of vision. And so this particular patient came from out of town and he just wanted to get in as soon as it came in. So the lens arrived at our clinic and he basically came the next day. So we put the lens on and he was 20/40 and 20/30 through it. And then he went out, got some coffee or lunch or went shopping a little bit, came back and had about a line of improvement in each eye just with the lens settling over 3 hours. And we had a -0.5 and -0.25 20/20 wow vision. So pretty good stuff here. And this is these images here are kind of the real kicker on, such a fun case where we just totally knocked out that coma. 91% improvement on the RMS, which is not typical. So I don't shoot for this every time, but this kind of set a high bar, being one of my first patients who had the ovid scans with the chroma HOA correction. But just what an amazing improvement. And then here's the left eye. So, just as good, 71% improvement there. So we ended up having like a 0.12 HOA on the right eye or RMS on the right eye and a 0.22 on the left eye. Here's the right eye before and after. So the blue and red bars are the lower order aberration corrected, or just your typical Zen lens. And then the gold bars are our HOA lens. And again, just a really amazing outcome. And again, part of this goes back to his lack of severe posterior float changes. Again, like we were able to neutralize a lot of that just because there wasn't a ton to start with. And so that's something to keep in mind too. When you have a patient who's got the 1.6, like Zach was working with, and you cut that in half or more down to 0.7, that's still a huge improvement in these patients' vision quality. Where again, for here, his posterior cornea was relatively less severe compared to your guys' cases, and which is why we were able to just really knock those HOAs down and provide that, 20/20 wow experience. And even at 80 years old, seeing, better than me at certain times in certain lighting conditions. So that's a really fun opportunity to be able to present that to our patients. And, I've only had this technology for a short time. You've both had it longer than me. And man, this is just really fun and a really, again, to me, it feels like it ends the fit a lot sooner because I know I'm going to finish the optics through this technology. So as soon as I feel comfortable with the fit, I'm moving on. And so in a way, I almost feel like I'm a little faster with the HOA, where some people complain that it actually takes more chair time and this kind of thing, where for me, it's nice and easy to, again, kind of draw a line in the sand and say, okay, now we're going to hammer home your optics within the next 2 visits. If there are any questions, there's not many coming through here. It looks like, Jason, you've taken a couple. Thank you for typing in some of those answers. Is there anything else you guys want to add to the conversation here?
I might just ask you two a question. Are corneal scarring, is that a contraindication or just a proceed with caution?
Yeah, it's going to obviously reduce the potential So you just have to proceed with caution when recommending to a patient. I find that when a scar is particularly significant, it'll show up on your HOA scan. You'll get, when you do the scan, you'll see the green, the Hartman Shack display after your scan results come in. And where there's no data, it shows up as like a red X. And when you've got a corneal scar that's significant, you're going to get a lot of red X's in that area. And that just tells you that it's not getting data. And those patients, it's not that they won't benefit, it's just that it won't be as significant. So I think it's okay to proceed, especially if when you take the scan, you don't have a lot of red X's on your outcome, that the points are coming back through. Even if there's a scar, but if it's obtaining data through that scar, I think you're fine to proceed.
Yeah, I would agree. A lot of the times too, like it'll say the scan isn't that great of quality, but then the engineers actually go in and like manually um, read those values and do the best they can there. So I would say go for it if you have a scar, especially if you can, get some good quality measurements. Three quick questions. We'll just fly through them here. Do you know if there are some publications that describe values of aberrations found in typical, normal, or healthy eyes?
I'm not sure of any publications off the top of my head, but far as from my perspective, it was always when we worked at laser vision correction, we always talked about 0.40 being the threshold for normal. And I think that's kind of what it shows up on your scans. If you're at 0.40 or below, it shows up as green, and above that, it'll start up as a borderline value or
Yeah,
abnormal.
for us, borderline was point is point 0.7.
I'm sure it's out there in the publications. I just don't have it off the top of my head which reference that would be.
Yeah, I try and use that green line. So if you're hovering around the green line in that ovid scan, to me, that says kind of normal-esque. Is reducing the HOA possible, making the peripheral curvature at eighth corneal ring intermediately? Sorry. Jeff, I might have to have you reword that question. We'll go to your previous one here. If the patient with KC complains of HOAs, can flattening the base curve, will that improve the aberrations?
And there's always the idea that if that there's always the thought that that's why some patients would see better with flat fitting corneal GP lenses because you were mashing down the cornea, flattening it out. You were improving their posterior aberrations while you were fitting them too. The problem you run into then is do you cause scarring and other issues? And that's a fine line to walk. You're not going to fit a scleral lens that way. You're not going to fit a scleral lens that compresses the apex of the cone so hard that it flattens out the posterior float. But obviously, yeah, anything you do to alter the cornea tissue itself physically could affect their HOAs.
Oh, you're on mute, Brooke.
You're muted.
How did I do that? Anyway, thanks guys for spending your time with me talking about chroma. And Jason, I think you and I are up next. Chat a little bit about sclerals in practice.
Great. All right. Thank you, guys. We'll roll into our next video here. So we'll get that loaded. But I love those cases. It's great to see chroma in action. And I love your perspective that it actually doesn't add to chair time. It can take away from us tinkering with their prescription. So that's a really awesome perspective to have.
Yeah, you kind of
So
just get through it. And like Zach was saying, to me, it's just I draw a line in the sand. Like your fit's great. Let's keep moving. And I stopped trying so hard on like every little last
Mhm.
cross cylinder over refraction. But anyway,
yeah.
before we present our last CE, we need to have a little break between any sort of sponsored material and CE content. And so Jason and I were chatting the other day, and again, for those of you who watched the beginning of the promotional session, Jason and I have a long history together. I consider him, my major mentor in my career. And so I've had a lot of time to poke his brain when it comes to contact lenses in general. And so I thought we'd have just a little coffee talk here about scleral lenses. And for those of you who are curious about, getting started in practice, being more successful, and, just kind of streamline everything that you do. This is meant to be kind of an open session. So I'll be watching the Q&A and the chat. For clarity, let's go ahead and throw them in the Q&A box, please. And we'll kind of answer those as we go. But Jason and I have about 15 slides for about 30 minutes for us to go over just all things scleral lenses, and we'll see where the chat takes us.
Okay. One thing I wanted to say, Brooke, and I've
Yeah.
been kind of holding on to this the last couple talks is, um, okay, quick story. So I had a patient some years ago who I was fitting in multifocal contacts, and this applies to any patient though, right? And one of the little things I like to do is, and this is determining, kind of getting your 20 happy, right? Because we know like with some of these things, the acuity isn't the whole story. So I always have this little thing I like to do with patients, and I put up a chart with like 20, 50, 40, 30, 25, 20, right? Multiple rows. And I tell them to look at the chart, and I don't want you to read any letters, but on a scale of 1 to 10, where 1 is completely terrible and blurry and 10 is completely clear and crisp, how clear is the chart? Okay. So I had a patient once who I asked that question, and she had just read the 2020 row on the chart in her multifocal contacts. And I said, how would you rate it? She said, it's a 1. I said, no, maybe you didn't hear me. 10 is good, 1 is bad. She said, yeah, it's a 1. I'm like, how is it a 1? You just read 2020. She said, because I have like 5 images of everything up there. Okay. So she read 2020 and she thought it was horrible. This is exactly what is going on with our patients. And I really should start getting to the point with my HOA correcting patients of asking them that question. And the reason I do that is that it's an objective, subjective question. It's the patient's subjective impression of their vision, but giving it a number so that when I put a different lens on their eye an hour later and I ask them the same question, we have a reference point. Because just asking a patient, how clear is that? "Yeah, this looks good." And you put a different lens on it, well, I think it looks better, but I have nothing to compare to because I didn't pin them down to a value on the first lens. So the point that was that it's possible to be 20/20 and have terrible vision. And we shouldn't ever assume that just because a patient sees the 20/20 row that they're happy with their quality of vision.
That is so true, and I completely agree with that. You know, when we used to do clinical studies for contact lens comfort and things, patients had to grade certain aspects of their lens wear on 0 to 100, but and that's kind of arbitrary. It's like a big, big number. But then at 20, 40, 60, and 80, there were descriptions of those things, and that
Mhm.
really helped the patient pin it down to, 67 or whatever it is. And so we maybe don't have to go 0 to 100 with the vision quality, but I do like your approach there where it's like my vision quality is a 1, and that's our job. So again, to kind of like let go of that 2020 line and have, the patient's feedback and experience on that it is really valuable when especially when you can't get them any better with an over
Yeah.
refraction too. That's
Well,
just
and if the patient replies to that question and says it's a 9, I'm probably not going to worry about an HOA lens.
yeah.
If they
Yep.
say it's a 2, I probably will be talking about an HOA lens. So we know there's
Yeah.
a lot of improvement of quality to be had.
Yeah. Um, so let's talk about lens selection because one of the
Mhm.
common questions that I get from new scleral lens providers is they're like, I just don't really know where to start.
Mhm.
And, do you look at your topography? And a lot of the times they'll come up and they say, I have this case and their max K is like 78. What do I do with that? And so what information do you use? Do you use topography? Do you just look at the eye? How do you pick a lens from your diagnostic set?
Sure. Well, if you're fitting Zen lens or any lens that has a fitting step-by-step process, you should follow that in general, right? I mean, you shouldn't deviate from the fitting process unless you have some great information about some unique aspect of this case. So I'm always, first thing I'm looking at is the corneal diameter, the HVID or horizontal white to white, because that's going to determine which diameter I fit every time. I don't deviate from that. Second thing is I'm going to look at the corneal shape. Yes, I can see from the front elevation map, the apex of this cone is very near the center. Definitely a prolate shaped eyeball, prolate shaped lenses going on it. Beyond that, when I pick a lens, so the deeper a cornea is, like a cone
I
that's
have
a
it.
78K is probably going to need a deeper lens than a cone that's a 52K. And so, yeah, this was something that I always make up. And when I teach my class, my advanced contact lens class, this is one of the slides. And you just know that going from left to right, that post LASIK, post RK, milder cones are going to be shallower eyeballs. And as we get into more normal corneas, medium diameter corneas, moderate cones, we're going to get a little deeper. And then as we go on to advanced cones and grafts. But the other part of that too is the corneal diameter affects a little bit too. We talked in the first lecture when we were talking about scleral shape, that the cornea is on its own reference sphere and the sclera is on its own reference sphere. And so the corneal depth, the cornea has a deeper curvature. So the bigger your cornea is, the more that steeper reference sphere occupies underneath the lens. So smaller corneas will need shallower lenses and bigger corneas will need deeper lenses. So you can really just, you can look at an eye and I can go, well, I know this patient has let's say this patient has a 12-2 cornea, and they're keratoconus. So I'm saying a 17 millimeter prolate design, moderate cone. So I probably want the fourth lens in my set. And it looks like it's probably gonna need a toric would be my best guess. So right away, I know right now I'm at prolate 17, toric lens number 4 out of 6. And so even if you don't have a scleral topographer, you can get pretty good at estimating the right lens in your set based off of the map you're looking at. Any
Yeah,
thoughts on that back at you?
yeah, I was gonna take the exact opposite approach where, looking at this, if this is a pentacam scan, but the a topographer is going to give you the top two boxes. So the axial is on the top left and the elevation is on the top right. And you can get this from a topographer. And so you can see that on the axial map, it has a 62.3, from what we can tell, maybe the max K is roughly in that location. And when we think about Ks in the 60s, oh, that's so deep, it's so tall, I'm going to grab from the top end of my fitting set. But if this cornea was 11.2 in overall diameter, and then you go and look at the elevation map, next to it, that cone shape is relatively small. It's not this big, massive cone on the front of the eye. You could probably get away with something on the shallower end of your set.
Mhm.
And so it's not necessarily um, getting distracted or getting misled by the axial curvature, because that's just a description of curvature. It could be
Yeah.
curving outward at you, or it could be curving away from you as well. And so it could be an area of shallow cornea too.
Yeah.
It's just a rate of curvature. So I have transitioned my residents and myself to, okay, here's my axial curvature. Here's where the visual axis, here's where things are kind of messed up because of all the curvature happening. But then I move over to the elevation map and I look at my best fit sphere. Okay, I have a 6.9 best fit sphere. And at 6.9, that's like a 49-ish cornea. For rate overall, it's a 49 best fit sphere, 49 diopter. And overall, that's not as steep as maybe the 60, 62 had misled us before. And that, the cornea is roughly above in the red there, maybe I think it's 52 microns above that best fit sphere, which all in all isn't a ton. So if it's a small cornea, it's a small cone looking at the elevation map, then I may grab from the shallower end of my fitting set. But again, the cornea in itself really makes a difference because as you get bigger, that depth gets bigger too. So the size of the cone and the size of the cornea are what I look at when I'm trying to determine. I want the best chance that I have to pick a lens that's pretty good out of my diagnostic set so that if the first lens is too shallow or too deep, my next lens will be the appropriate depth.
Yep.
So I'm not trying on lens after lens after lens. Um, and then we have a little bit of discussion about, limbal shape in a few slides, but I think sometimes early fitters get a little confused about chamber size and lens diameter. And so could you just talk a little bit about, without getting too specific about the limbus, because we're definitely going to get into that, just what is the chamber size and then how does that differ from diameter?
Sure. So the chamber size is the junction between the curve, which ends the vaulting part of the lens and starts the haptic. And so whatever that is, again, it could be like you have a base curve, second curve, third curve. It could be the junction between the third and fourth curves of the lens, could be the fourth and fifth, depends on the design of the lens. But the manufacturer knows that. They know that. I mean, even though this is a scleral lens, it still has the same construct as like a corneal gas perm, where we have a base curve, a second curve, third curve, fourth curve. So the junction between the point where the lens is intended to vault and land and then align is that end of the vaulting chamber of the lens. And that, you could have a 17 millimeter lens that has a vaulting chamber of 14 millimeters, But you can also have an 18 millimeter lens as a vaulting chamber of 13 and a half. And so it depends on the way that the whole lens is constructed, and it's important for you to understand what is the point at which I transition from intended vaulting to intended landing, and work with that diameter versus your corneal diameter more so than the overall lens diameter itself.
Thanks. I'm at the office and our cleaning guys just showed up, so apologize for any background vacuum
I can't
noise.
hear anything. You're good.
Okay, good. Let's move on. And another thing that sometimes we get some questions on is just like, hey, when you have a patient who's really challenging to get the lens on, like, what do you do when their eyes are moving all over the place and that kind of thing? And Jason, you and I have very similar fitting styles because of our history of practicing together. But we the way we insert lenses is actually different. And so we actually at one point thought, well, maybe we need to duke it out about insertion techniques, but we each just took a quick video about how we kind of brace ourselves and set ourselves up to maximize eyelid control when we're placing lenses on eye. So I'll just kind of talk you through what I'm doing here. So I usually put my forearm against the patient's forehead to make sure I can get, and I always use two fingers to control the upper lid. And I'm using a plunger on eyes. This is my scribe here, and she's a great patient. But even on eyes that are like squeezing, rolling backwards, that kind of thing, I'll use two or three fingers on the upper lid when I'm bracing my forearm against the back of their head, and then I tilt. Oh, let me just gonna play it one more time. I actually tilt the lens because I'm on a plunger that has a little suction. I tilt the lens away from the eye just a little bit so that I can slip the front edge of the lens underneath into the gap, the fornice or the fornix between the eyeball itself and the eyelid. And then if that patient's eyeball is rolling backwards and I tell them to relax, look down, as soon as they start to look down, I just roll that lens right up on the surface of the eye. And so I'll just do that one more time. So as you see, I'll just kind of roll it up toward their forehead, and that kind of keeps bubbles from coming in, even if they're kind of bobbing up and down with the way that their gaze is. And so I like to use a plunger that has suction on it when I'm working with difficult patients. And Jason, I know you use a ventilated plunger and don't use any sort of suction or stability. And I don't think I could do that. If somebody gave me a ventilated plunger in a workshop, I'd be like, this is not for me. I can't do it.
Well, it's just what I got used to, I suppose. So yeah, I have the patient hold their lower lid for me, and I hold the upper, and I just make sure I got clearance, and I just put it on. And the thing again is, without ventilate or without suction, the minute it touches the eye, even if it rolls up, the lens stays with the eye rather than with my plunger.
Hmm.
So I don't have to worry about it now. In the rare occasion the patient starts to roll their eye up before I hit the lens, it's obviously going to be an issue. But otherwise, yeah, I mean, it works for me, and I'm just a quick pecking it onto the eye real quick and getting it on as fast as I can.
Yep. And then for removal, oh here, I
Oh
liked
yeah.
that, this model here, man, just like such a great model in this video.
Yeah, right. Well, I'm my own subject much of the time. So yes, you can use a stand sometimes too. You just put it on there and lower yourself down onto it. Works
Yeah.
great.
This
If the
is a really
patient
nice one for
needs to,
patients
yeah.
that do need to have good lid control themselves.
Mhm.
Maybe they have a strong blink reflex, but if they, rather than using, two fingers to hold their eye open, they can use a hand for each eyelid and lower themselves down. It's also great for patients who have some hand tremor and just control with the hand itself, even if they're, have good lid control. It just keeps the lens steady, keeps them from getting bubbles in the lens. And there is a number of stand options out there nowadays. And so they're really good resources. And you could really talk to anybody on this seminar or this summit today on stands that they recommend for their patients, because there's probably a good 5, 6, 7 of them out there right now that are great for patients with a varying range of costs, depending on if you want it to be lit or travel or, compressible where you can fold it down and those types of things. So another great little tool for those of you, again, just getting into scleral lenses. This is kind of like a quick way to teach patients to put it in, especially for those that are really unsure about their ability to handle lenses. I have patients who are 80, 85 years old using stands and doing well.
Mhm.
All right. Lens removal. So There are two techniques that, again, we might differ slightly on this. It sort of depends on the patient, but you tend to take the lens off from
Mhm.
bottom.
Yep. So have the patient look up slightly, and I touch right between the pupil and the lower edge of the lens and just touch as gently as possible. Obviously, pushing any harder than you need to will just create suction. But it's important that you have the patient looking up slightly rather than down, because then when you look down, it doesn't work as well.
And the other thing that I thought was important with you is that you have really good control of the upper lid on
Hmm.
this because the lid
Well, and
has to
I
that
always put
way.
liquid on the plunger too, obviously, just to make it suck better. But yeah, I mean, you've got to not just pull the upper lid up, but pull it away from the eye if you can, because if you get it away from the eye, then it doesn't touch the lens and hold it or pin down the lid. If the upper lid is touching the lens at all, it's going to be fighting your ability to pull the lens away.
Yeah, and I usually take the lens off from the 12 o'clock position
Hmm.
rather than the 6 o'clock position. And I just use a similar approach where because I have them look down and then I place the plunger again between the pupil and the edge of the lens and I pull the lower lid away from
Hmm.
the lens too. And then the reason I started doing this when I was, trained was if by chance the patient blinked and the lens broke suction, then if they blink, they kind of bat the lens away from the eye, which is the importance of you holding that upper lid in up gaze. And so a lot of the times we teach patients to take the lens off at the 12 o'clock position too, but by the time they get good at it, they come in and they pop it off from the bottom. So eventually they come around and do it that way once they have good lid control. But this is something that I found maybe reduces even teaching patients to come from the top reduces those like calls where they lost lid control and they blinked on once the suction was broken from the lens and then they give themselves a small abrasion or a small scratch or sensitivity to the cornea and that has reduced that but again we kind of teach patients both ways encouraging them in the beginning to start from the top so it's all about patient education on like making sure that they minimize the incidence of their lens catching the front of their cornea when they're inserting and removing their lenses. Um, I liked this video that you sent to Jason on, maybe the plunger is in the wrong spot. It's in the right smack in the middle of the lens, and they don't want to, feel that pull of their eyeball. They need to release the suction and try again.
Yep.
So this is a good tip, and that not everybody thinks about this.
Well, and the first problem here is I'm looking down, and you don't look down. I teach patients always look straight ahead into the wall mirror, and keep your chin up while you do it. So the lens again is up a little bit. I don't have patients look down into a desktop mirror. We always look straight into the wall mirror and look up slightly. But if it does get on there, rather than them pulling and freak out, I just show them you can just slide your fingers down and pinch it and it release it, and you can start over again. Just don't panic. It's okay.
Yeah, and sometimes where you have a really, really tall lens, the junction between the chamber and the landing
Mhm.
is really abrupt. And sometimes like the plunger doesn't quite grab on and then it slips to the front of the lens. And so this is a good way, this is a good tip that sometimes I forget to tell new fitters about in just making sure that that, hey, like you can try again. You don't have to necessarily um,
Keep
uh,
pulling.
worry. Yeah, yeah, you, like yank it off to break that suction.
Right. Yep.
We do have a question in the chat, so this is probably a good one, a good time to break and do that. For someone just starting out, not expecting to be doing a lot of scleral fits, um, can you make some suggestions on affordable equipment that does things like topography, aberrometry, and some examples? And we actually have a question coming up, Jason, on those types of things, so we'll get to that question in just a bit. Um, Speaking of beginners, we when we were at ICSC last week and we were talking about different approaches and fitting eyes with keratoconus,
Hmm.
um, John Gelly's made an interesting comment that said, when we're comparing corneal GP lenses to scleral lenses, we shift one problem for another. Where corneal GP lenses, the concern was always the apex, like you can see in this image here, really flat GP, just abrading the apex of the cone. Where in sclerals, kind of the challenging area is the limbus, like we had alluded to earlier. How do you look at limbal shape and how do you promote proper fitting of the limbus? Because it really is the source of a lot of problems. prolapse, fogging, lens movement. It all has to do with alignment at the limbus. So can you tell us,
Yeah,
what,
I
how
think
do you tackle that?
it's critical to differentiate between issues of limbal health and issues of fitting the lens around the limbus. Um, yes, fitting around the limbus, getting it to fit well is a challenge. Limbal health is rarely a problem, right? I mean, most of our patients don't come back for their annual checkups with all sorts of limbal complications from their lenses. Most of the time, we fit them right to begin with. Their limbus is just fine and healthy. Okay. Um, so tackling proper fitting in the limbal shape, it goes back to this concept that instead of looking at the end of the lens, we should look at the end of the vaulting part of the lens, and that's the part to get right. And knowing that our eye is typically toric at whatever chord diameter we're going to land the inside of that lens on, that we put toricity in the chamber of the eye. Just like 10 years ago, we all had this great revelation. Oh, we should have all our diagnostic lenses should have toric haptics because before 10 years ago, they were all spherical. The reality is probably all of our lenses should actually have toric chambers, not toric haptics. It's actually far more critical that the chamber be toric than the haptic be toric, because that's where most of the toricity of the eye is at the internal landing point or inside. So the proper fitting it is just to if you've got an instrumentation that tells you about it, great, use it for sure. If you don't, use fluorescein. Put a lens on and look at the fluorescein pattern.
Yeah, and that kind of alludes into the next one. There's probably some docs on here that are considered maybe seasoned fitters or mid-level fitters. And I myself, 2, 3 years ago, drifted away from using fluorescein because there just wasn't a whole lot to see or what I thought. But now that we've really brought refocus back to the chamber shape and chamber size, and the way that the lens lands around and over the limbus, in my practice and in your practice, as you've said, fluorescein is making a comeback.
Mhm.
So can you tell, like, how do I use
Yeah.
fluorescein in
It's
the way
not to
that,
visualize the central clearance necessarily. Like what that was the reason we did it for the most part before, right? Oh, it was easier to see the vault. Okay, who cares about the central vault? That's pretty easy to see. What we really want to do is we want this to be looking at the limbus and not just looking for limbal clearance, but for looking for evenness of limbal clearance. Do we have minimal limbal clearance in one meridian and excessive limbal clearance in the other meridian? Well, that means that we are not landing with equal depth to the matching the shape of the eye in one meridian as we are the other. And so then we need to add depth to the one meridian that's got more clearance. We need to bring the lens down and contact it to the eye surface closer to the limbus than we do out at the edge where we would have originally done it. So fluorescein is there to look at limbal clearance more than anything, I think, and to look for the evenness. And again, to do this, you've got to center the lens. You can't look at it with the lens decentered inferiorly. It's just garbage information. Push the lens up into a centered position, then look at your fluorescein pattern, and that's going to tell you everything.
and like a good little mentee, or I should say mentees, Zach and I both have videos in our next lecture on troubleshooting on how to
Perfect.
manually center that. So
Love it.
we will definitely discuss, the importance of centering a lens to look at everything else that's going on. Another thing for, you fit thousands of patients and, probably tens of thousands of lenses at this point. What's the end point to you? When are you comfortable?
Yeah, when the patient says they can wear it pretty close to as much as they want to be able to wear it, what works for their lifestyle. That's different for every patient, right? Some patients are satisfied with 8 hours a day. If they're a retiree and they don't get up and put their lenses in till, 11 a.m. and then they can wear them till after dinner and that's good enough for them, then if they're happy, I'm happy. Some people that work full time, they want to be able to wear them 15, 16 hours. That's my goal then. I want them to be able to wear their lenses the way they need to. Visually speaking, it's the best we can get them, and that could be adding toric front surface. It could be adding HOA optics now. It's giving them the best that I can give them. And if I can't give them perfection, then I'll just be honest with them. This is as good as we're going to get it. But if I sense we can do better, I want to do better. How about for you?
Uh, yes, I think right now because we have so many options to change things. I mean, you could just like tweak designs forever and ever. And the conjunctiva is not the same every time we see the patient, so that's another kind of spongy or soft spot on the endpoint because it's just there are some changes to the eye in between visits. But thankfully it's a forgiving conjunctiva. And so if sometimes I feel like there's maybe a touch more compression than before, but again, patient is asymptomatic and there's no significant conj staining when the lens comes off, then I'm usually good with it. But again, it to me, it has to kind of be driven by the patient. They have to come in and be like, yeah, like these are really comfortable and I'm really happy with how I'm seeing. And then I kind of like let myself off the hook and I can say like, okay, as long as the cornea is healthy, if I see something, I just need to let it go.
Yeah.
And uh yeah, that's kind of what I use. Oh, I see Ariel's on to give us
Yep.
our cue. I'm gonna ask, we're just
Oh.
gonna get to that one question for the one question that did come through on the Q&A. For somebody who's starting off, Jason, what kind of tech do they need?
Yeah, I mean, a basic topographer is nice because it will, if it'll measure corneal diameter, it'll give you an idea of corneal shape. That at least gets you narrowed down into your starting point for fitting. As you do more fits, I'd say, adding, you can add scleral topography, you can add aberrometry if you're doing more and more fits. If not, and you just say, I want to be able to do some scleral lenses, but if it gets too challenging, just have someone to refer to in your area that has the advanced stuff. So if you reach a point where you think I can't get it any better and they're not satisfied, you've got a place you can send them for the next step.
All right. I think we can wrap it up. We met our time limit that we needed to, Ariel.
Yes.
All
Yeah, and we
right.
can save some of those questions for the Q&A that we have with you guys
Oh, perfect.
following your scleral lens troubleshooting presentation.
Sounds very good. Thank you. Thanks, Jason.
All right. So we will go ahead and load up the scleral lens troubleshooting PowerPoint, and that will be with Doctors Brooke Messer and Zach Collin. I like your background, Zach. Looks like you're like a true mountain man with the beard and the
That
trees.
particularly wasn't the intent, but I just got tired of looking at the white walls. So yeah, built some background into the office.
That's awesome. Well, cool. Well, I'll let you guys go ahead and jump right on into your scleral lens troubleshooting presentation.
Thanks, Ariel. All right. Last one, Zach. We're wrapping up the education for the morning for the attendees. So again, thank you all for being here. And now we're going to talk about troubleshooting. So we've kind of got the basics down. We talked about what's coming down the pipeline with new tech. And now we're going to talk about maybe what most of us spend doing is troubleshooting and taking it from the diagnostic to our end game. And so here are our disclosures. Like I mentioned before, Zach, Jason, and I go way back. This picture was taken maybe a year and a half ago or so when we were all happened to be in the practice at the same time, just for a visit, which was really nice. Um, and when we talk about troubleshooting scleral lenses, there's kind of two aspects of it. And you're the one who actually brought this up, Zach. And I think this is a nice way to separate it on how patients sometimes drive the troubleshooting and other times it's us because we know the patient will have a problem if we don't kind of dive in. And so this is how we broke up the discussion today. We're going to talk about patient complaints and when they bring us problems, and then also when we see problems that we need to address. And so that's how we'll kind of navigate through our fitting or our fitting. Too much work. Our discussion today. So Zach, can you tell me about when you're looking at a cornea and the cornea shape, kind of how that impacts your initial steps in the fitting process?
Yeah, most definitely. I mean, obviously, if you have a profilometer, that gives you somewhat of an advantage to, from an elevation standpoint on height sizes and corneal shape on what you want to put on the front surface of the eye. I often look with the slit lamp first, and when you do this more and more, you just kind of get a general sense like, okay, this is a short lens or a deep lens or shallow lens, or I mean, so just looking at it and taking experience is going to give you some insight, but also looking at the cornea shape as far as the location of the highest elevation is super important on being successful and choosing at least the first lens. it's really difficult if you put a lens on that's not even close and then kind of merging into that right spot eventually takes some time. So from an efficiency standpoint, getting that tallest elevation is nice. And that's where like if you have a center cone, you're going to be leaning towards a prolate lens. I mean, the image to the far right is an RK patient with a really inferior ectasia. That patient, I fit in an oblate lens just because I needed that higher elevation, that mid-peripheral spot. Yes, they have more clearance superiorly than we need, but really there's kind of limited options in that scenario. Saltzman's patients, I think, are some of the most difficult patients to
Mhm.
fit because they have that superior nasal like elevation typically, and that's like a spot
Yep.
that limbal clearances and mid-peripheral clearance is just really tough to come by based on the lens decentration situation.
Yeah, and thankfully we'll troubleshoot those in a few slides. I did add this image here, similar to what Jason and I were chatting about. How don't be fooled by depth when you're looking at the axial map. Flip your topographer over to the elevation map so you can get a good idea of what the shape of the eye looks like. For example, here we have kind of a max K somewhere in the 56 or 57 on the sagittal or the axial depth or axial curvature map, excuse me. But then when you flip over to the elevation, the eye actually doesn't look all that impressive. It's a 7.88 radius of curvature, which is, flatter than 45. So it's probably in the 43 or 42 base curve, and it looks relatively with the rule. So this cornea isn't all that exciting, even though the apex of the cone, it's just a very small cone, even though it's steep. And so again, this type of eye is one where I would kind of stick to the shallower end of my fitting set when I'm working with a lens that's made for keratoconus. The other thing is then, looking at the limbal shape, and I like this topography or the scleral topography that you added here. And again, if you don't have a scleral topographer, that's fine. We're going to use this as, ways to demonstrate how the limbus can look. It's not that you can't do it without it. I only added profillometry to my practice in January, so I've been fitting, roughly 10 years without a profilometer. And it's actually 15 years now that I think about it. But inferior or at about the 4 o'clock position there, you can see, the red ring is the cornea sphere, and then outside the red ring is the sclera. And you can see the limbal area has some elevation, and in that kind of inferior nasal, if this is a right, yep, inferior nasal, this is a right eye area where the limbus is a little bit elevated. And so knowing all of those things can tell us, is the lens going to shift to the right? Is it going to shift to the left? Is it going to shift inferior by understanding what that limbal shape looks like? If you don't have this, that's where, again, putting fluorescein in the bowl of your lens and then kind of nudging that lens in different directions will help you identify, oh, there's a limbal elevation, or this limbus is, deeper here compared to taller over here, and those types of things. And so fluorescein in the bowl can help you mimic the information that you would gain from a scleral profilometry. When we talk about scleral shape, the scleral shape study group, they've probably put this data probably 5 or 8 years out ago by now. And they actually found that very few eyes are actually spherical in the scleral shape, and that most are actually irregular in its shape in the sclera. Thankfully, we can get away with things like basic toricity in the landing curves or the chamber of the lens, even with these asymmetric elevations or irregular toric eyes that we see. But it just kind of goes to show that if we're fitting a scleral lens with a spherical chamber and a spherical haptic, we're probably missing opportunities to improve the relationship of that lens to the ocular surface, as over 60% of patients have no pattern whatsoever to their scleral shape. Um, this here, what I wanted to talk about again was just to kind of hone in on if we're going to understand how the lens is going to fit on the eye. I think we've hammered it enough by now, so maybe we don't have to spend too much time here, but don't be fooled by the axial map. Look at the elevation map. And so, Zach, if you look at this map, what do you look at when you have a topographer or tomography? Like, what do you look at when you're getting started with your fits?
I'm looking at where the highest and lowest locations are at. Are they symmetrical? I mean, this is obviously a corneal image and doesn't have anything to do with the alignment curve, but you can tell that you're going to have more like you need a deeper lens in the vertical meridian. And so and then presumably if you don't have a profilometer, there's some translation or some assumptions you can make about this person's sclera. And so I would anticipate this lens, the flat meridian, to stay within the horizontal meridian. And so putting a toric alignment curve or a like quadrant, a dual sag lens on right away is probably going to increase your first lens fit success.
Yep, I would agree. The blue in the vertical meridian, the lens is probably going to rock in that meridian and it's going to teeter-totter on the horizontal meridians where we see that red. So the lens is going to come down and hit there first, and then it's going to rock back and forth as it tries to align with the superior and inferior meridians. And that's where those dual sag or quad sag chambers can really make a difference right away. So if I see something like this, I'm like you leaning into probably a dual sag lens so that we can better align in the mid-peripheral cornea and the limbal landing. And this one here, I just wanted to point out again that this cone is inferior, but it's relatively small, and it's a very prolate shape. You can see that the cornea gets very tall and then it shallows out. And just within that central cornea area, we go from plus 60 microns down to negative 53. So there's a pretty big elevation change. And so to me, this is just a very prolate cone, and I'm going to keep that in mind when I'm selecting my lens shape so that I don't have excessive clearance in the mid-peripheral cornea. Because if I pick kind of like a shallow curvature kind of thing, we're going to just overvault that mid-periphery and create a lot of problems with, just a well-fitting lens. There's too much fluid in there, so the system will be heavier, creating inferior decentration. And so again, I'm picking something that has a relatively prolate shape to the chamber as well. This slide here, it's geared toward docs who are both, entry level and, those are already experienced, because there's a lot of terminology around scleral lens fitting. And I like to use this as just a quick run through on, we're going to go from, work down through these terminology, and so that you kind of know going forward that we're all on the same page when we talk about certain parts of the lens fitting. So first off is going to be the sagittal depth of the lens, and that's if you would take the lens and put it on a tabletop, it's going to go from the tabletop to the tallest portion of the lens. And so again, that's going to be the sagittal depth. Next, we're going to talk about, the vault of the lens. And the vault is the tallest part of the cornea and its relationship to the back surface of the lens. So what is the narrowest vault? Sometimes, when I have students or residents assessing lens fits earlier in their education, they'll go right across the visual axis and say, oh, the central vault is, 600 microns. But they don't see that the cone is inferior and it's only, 100 microns over the apex. And so it's important to know the description of the vault is over the tallest point of the cornea. And here's an example here for those of you who are newer to fitting, having fluorescein in there really helps highlight the vault so that you can kind of look at that tear film, move that parallel pipe across the entire cornea to help identify those thinnest points of vault. Next, we have the chamber size. And as Jason mentioned earlier, it's the innermost landing point of the chamber. So it's basically where, if you start at the apex of the lens, where it transitions from the limbal clearance out to the landing curves, that's going to be your chamber size. And some lenses can, increase chamber size, through increasing diameter. Others can change the backside of the lens to increase the chamber size without adjusting the diameter. There's various ways to make your chamber size bigger and smaller so that you're proportional to your cornea size. So it's important to understand the chamber size of the lens and how you can make it more proportional to your cornea. Big corneas, big chambers, and vice versa. Next is limbal clearance. And the limbal clearance is the angle at which the lens approaches the landing on the sclera just outside the limbus. And changing your limbal clearance just opens and closes, like an alligator or a crocodile, if you would. So shallowing the limbal clearance is going to close the mouth of the crocodile, bring that closer to the corneal surface, and increasing limbal clearance is going to open it wider so that you have a steeper approach to the ocular surface. in most designs, when you talk about limbal clearance, it doesn't move, the junction of the angle. So it doesn't move where the lens touches the cornea. That's chamber size. If you want to move that point in or out, you need to change the chamber size. Limbal clearance only moves the lens up or down, to open or close that angle of approach. And so that's just important to understand that you can't just increase limbal clearance if your chamber size is inappropriate. So if you feel like you're landing on the limbus, you can't increase limbal clearance. It's not going to make a difference. Next are our peripheral curves. And so those have a number of terminology that's appropriate. We have our peripheral curves, haptics, landing curves, those types of things. And you can flatten or steepen those curvatures. And nowadays in many quadrants, there's, torics, there's quadrant, there's even, some designs that can go into 8, section lenses or even freeform now to where they're completely customizable. So again, those are our peripheral curves or the landing curves. Toric landing curves are when we have an alignment in one of the misalignment in the major meridians. So here in the vertical, we're misaligned with a lot of edge lift. And so then you can bring in one meridian. Here's a description of blanching. And so when we talk about blanching under the landing curves of a lens, this one I fit way back when in residency. We use it as I use it as an example for blanching only. If you look at the chamber, that's pretty darn big, way past the limbus, and we certainly try and avoid things like that nowadays. But when we talk about blanching, the important thing to communicate in notes to yourself, and if you happen to be talking to a consultant, is where is the landing or where is the blanching happening? Is it underneath the haptic in its entirety, kind of like what you see here? Is it closer to the limbus? Is it at the edge of the lens, where I would call that more impingement? And so just understanding where the blanching happens is important. Like this one here, this is an OCT of a lens edge and it's digging into the conjunctiva. So I would call this toe down impingement. In my practice, this is not a rule for everyone, but when I write down impingement, to me, that tells me that it's the edge of the lens impinging on the conj, where blanching is more like the entire landing curve kind of pressing down evenly. But sometimes we have what we call heel down blanching. And in this example here, you can see kind of that whitening of the sclera right next to the limbus, but there's actually no blanching at the toe or the edge of the lens. And that means my edge is actually too flat. So I'm bringing down kind of the heel of that landing rather than the toe. And so if you just call up and say, hey, I have some blanching, most of the time they're going to say, why don't you go ahead and flatten the edge? But in this case, this whitening through here, that would actually get worse if I continued to flatten the lens. And so it's important to note where under the haptic is that blanching occurring. So we broke up the troubleshooting summary into vision, lens design, and then throughout the chamber, the cornea, the limbus, landing, working outward, and then lastly, our patient complaints. All right. Zach, do you want to talk about kind of like refractive astigmatism, how you address ORs? If you have, let's say you have a toric lens on eye and you refract with an overrefraction that has astigmatism in it, what are the steps you take to make sure that that overrefraction is predictable?
Yeah, so I think it first depends on where you're on the fitting set or the fitting process. So if this is the first lens that I've put on the eye, my trial lens, depending on the magnitude of the overrefraction of the astigmatism, I may not be ordering it on my first order. And so, because you want to align that alignment curve appropriately to get repeatable lens rotation. Not that you can't put it in, you can, but it just may be unpredictable if you're adjusting the alignment curve and then the lens rotates differently than you had measured on your first measurement. It may be counterintuitive. The magnitude also makes a difference too. I do retinoscopy on all of my individuals. And so I know if it's really there or if the patient is eating this up and not. But if they have 3/4 of a diopter of astigmatism, might not put it in initially until we get to the very end. Here you can see on the video, the black dot is a reference marker. We just want that lens to be as stable as possible so then you get as predictable as a result as possible. I
Yeah,
think, do you rotate this lens?
I don't make a huge rotation because I was trying to capture something else in this video. I don't have a good sort of misalignment video in my searches this weekend. But the what I was trying to show here is that you can see that I'm kind of nudging the lens around, and it just comes back right back to that same little spot. And when I achieve something like this, where the rotation of the lens is predictable, then I will add in my toric optics. So it may not be the first lens, but once I actually identify, okay, this is where my rotational point of rotational stability is, and now I'm just working on maybe limbal area, sagittal depth, those types of things, then I feel comfortable adding in the toric over refraction. And I would agree with you, Zach, that sometimes I work up in magnitude as well. If I have a larger toric over refraction for whatever reason, say 2 diopters, then maybe I add in just like 1.25 or 1.5 and then see where it lands, rather than, maybe the patient's taking a lot because it's just, there's a lot of optics going on in that first diagnostic fitting. And so I kind of work my way up. Sometimes that astigmatism can change a bit as we improve the fit of the lens. And so I give them, maybe 60, 70% of what they're wanting, so that at least when the lens comes in, they feel that improvement. They have less like smearing and glare, but I may not give it all the way. If we overshoot it, it's harder to kind of work backwards, in my opinion, and know that
Mhm.
it's a reliable power change. And so adding in just a little bit and having the, now that I have some lenses with like dual sags in the lens itself in my diagnostic fit, that helps me identify the point of rotation as well. So that if I put on, a lens with a toric haptic and it rotates to one spot, or I put on a lens with a toric chamber and it rotates here, and then I'm kind of looking at what my lens is going to be. I'm predicting the area of rotation just off of my diagnostic lenses. And so I am adding astigmatism in earlier than I used to, but only when I'm comfortable in that, like, the lens is going to rotate to 4 o'clock, just like you see here, then I will add it in. But if I can't predict it, then I don't add in astigmatism. Because if
Yeah,
it
I think
rotates
if
90 degrees away, then it's just a gigantic optical mess and they can't take the lens home anyway.
Yeah, I think if you get a front toric over refraction of either a diagnostic lens or a first lens fit, I just wouldn't be shy with the toric alignment curve, because you got to put enough in there to stabilize the lens. So be aggressive with the alignment curve toricity if you think you need a front toric.
I agree. Yep. Finding that spot where that lens is going to lock in is important. And thankfully, the conjunctiva is relatively forgiving. You can always, if you find that you're kind of impinging on the surface of the eye and creating a little bit of like maybe conj staining from the lens edge being a little too tight, you can always back it up. At least you know where that lens wants to go. How about higher order aberrations? We just had our promotional, talk about correcting HOAs, but I like how you point out and discuss when you have the opportunity, maybe if you're in a corneal specialist's office or an optometry practice that does have an aberrometer, or excuse me, not a tomographer, this can be through anterior segment OCT or a tomographer like this one here, and you see the back elevation of the cornea. Can you tell me about how you use this to identify aberrations?
Yeah, so in school, we all learned the aberrations with that triangle system. And to be frank, like, I kind of breezed over that. I didn't even know I was going to be in specialty lenses back then. And then in clinical practice, like, it wasn't making a huge, like, it didn't impact what I was doing on a daily basis. And not until I got an aberrometer did I start looking at these individual things. And so for those of you looking at these elevation-based maps, coma is going to be what affects a lot of these individuals the most. And that's going to be described on your mapping as an asymmetry from the top to the bottom from an elevation standpoint. So if we flip that elevation one in half, it's going to be steeper and more elevated, protruding towards us on the inferior side. And that's going to split the light on the patient's vision and cause that asymmetry and the focusing on the retina. And so I kind of make this joke as your tomographer, which is probably one of the more expensive items I have in the practice, is more expensive than my aberrometer, is my rich man's aberrometer. But as long as you can, in the infancy of the aberrometry system, if you will, I like matching up my aberrometry data with my tomography data, because it just adds reliability to the system. I mean, usually my aberrometer and tomographer, I'm only taking a single image, and just because they are fairly reliable, but it just is a double check for me.
I would agree that if something ends up not correct, you get an aberrometer or aberrometry corrected lens, and then maybe the patient's visual acuity isn't as expected, you could go back and look at that wavefront map and see if it matches up. So I like that. I like that approach a lot. Right now, when I'm doing aberrometry, I tend to take a couple scans just because I'm hypersensitive to repeatability. But even on those patients who have only taken one, they've done pretty well. But I think you're right. If you can match up, especially in that coma, like this big red hot spot there on that right map, that's a great tip to kind of maximize efficiency in the practice. Here's just a couple examples about, again, higher order aberrations. This is a scan taken over the lens, and it's going to highlight that coma and identify where kind of the highest aberrations that we see coming through the lens. And this one here, again, good candidate for HOA correction because there's really just a couple aberrations that are impacting that patient's vision. And then on the back side of it, we can reduce a lot of those aberrations. Sometimes we get, more on the second lens than we did on the first in some of those smaller or lesser significant aberrations down the chart. I haven't found those to be significant from a reduction in vision quality. Patients respond most to, really getting those big bars reduced.
I do think it's important to, and I'm just going to harp on this on all of the HOA lectures, is looking at the scale on the y-axis is important because that scale will change as the RMS values are going up and down. And so just quantifying that when you're looking at these things, because sometimes a tall graph actually has a small y-axis and may mislead you.
Yes, having an idea of what the top of the graph is it 1.0 like in this case, or is it 0.5? And that way it doesn't make you overestimate accidentally what the patient potential is. That's a good tip too. Will you talk about ocular surface, lens surface?
Yeah, so when my students come to me and tell me, and they tell the patient tells them that they have blurry vision, um, and the vision it's changing. I always want to have them identify, well, why is it changing? Because if it's changing, it can be multiple things. Can it be the front surface of the lens? Can it be the back surface of the lens, like a fogging situation? There's also corneal swelling or edema that can occur. And so your history can really lead you down almost a diagnostic scenario in these cases. An individual that has corneal edema while they're wearing the lens is going to be progressive and progressively worse. The video in the middle there, that patient's having front surface lens wettability issues. That's going to be a scenario where the vision's getting better, worse, better, worse. Um, and then if you have fogging on the back surface of the lens or in the chamber, again, that's just going to be progressively worse, and there's nothing the patient can do to improve it other than take the lens out, reinsert and then they back improve, where that would not occur if they had corneal edema. And so, frankly, I'm diagnosing a lot of this based on history because I like knowing what I'm looking for before I even go into the slit lamp. Obviously, you're confirming that and the magnitude of it when you're looking at the slit lamp.
Looking at that leftmost image, that's a really nice one that you added here. To me, when I see this, you kind of have a little bit of microcystic edema and some corneal
Mhm.
staining. And so if I had a patient like this, I'd maybe be looking at what are you using for your insertion solution or your filling solution? Because sometimes patients get confused with all of the solutions that we give them. It's a lot, frankly, coming, especially if they're coming out of soft lenses. And so one is like switching up the filling solution if they are using it properly, making sure that they're rinsing out all of their multi-purpose solution. If it's stored overnight in a multi-purpose, sometimes they just take it out and fill it and put it in, and then they're kind of sitting in that like old preservative, bowl. And so making sure that they're fully rinsing that preservative out if I see kind of a mild ocular surface reaction like that, as well as, at our dispense, we do give multiple types of filling solutions in their kit so that they have 3 or 4 of a few different vials to give it a try and see what provides the most comfort. Moving on to kind of lens depth and shape. Let's talk about depth first. When you're looking at optimal clearance, do you have a number? Is it a feel? How do you decide where to land?
I have a loose number. but it is more based on feeling. I don't use OCT to fit lenses, and so frankly, 100 is the same as 143, which is the same as 200 in my practice. Eventually, there's a point where too much is unnecessary and can be dialed back, and obviously, too little is on the cornea. But I do have some individuals who I will fit close to the cornea for specific reasons, whether it's an oxygen permeability issue or a tear fogging issue. I find that if I fit closer to the lens or close to the cornea, there's less space for that fogging debris to accumulate in the center, like axis of their vision. Do you have a specific what do you aim for?
Yeah, I would agree with you that it is, number one, it's case dependent and that we're always thinking about what's appropriate for this type of eye. Do they have a really spongy conjunctiva where I know they're going to settle more during periods of their lens wear, if they're autoimmune type eyes or something like that. And I would say in general about the thickness of the lens, most scleral lenses are going to be somewhere between 250 micron center thickness up to maybe 350 or 400 microns. And so to me, if the lens is on eye and the the fluorescein, as you can see here, is about the same thickness as the lens, then I'm usually pretty comfortable with that. The lens on the left, I think, especially new fitters, they tend to underestimate the vault. They'll look at this and say, oh, that's about 500 microns. Whereas if this lens is 300 microns thick, then we're looking at, 3x lens thickness, which is
Mhm.
about 1,000 microns thick. And if you have an OCT, I only use OCT when I'm troubleshooting. If I'm trying to figure out, and I use it more at the limbus, looking at conch prolapse or something like that. I rarely use it for sagittal depth. And but if you do have an anterior segment OCT and you're new to scleral fitting, I would encourage you to use it just so you can find out what does 100 microns look like. Because on this image on the right, that is about 100 microns, where I would love for all my patients to have just this like perfect 100 micron sagittal depth, where in when you look at it, you might be like, oh, that's so shallow. Like, let's increase the clearance. Where if this was at the end of an 8-hour day, I mean, this is beautiful. So I would love my patients to look like that. So I would encourage you to use it just to kind of educate and get your bearings of what, the lens on the left is at 1,000 microns and the lens on the right is at 100. So you just have some more accurate estimates. And then again, being really specific, looking at the depth of the chamber against the lens, which will be on the invoice or the parameter sheet. So you'll know exactly what the lens thickness is, and that'll help you kind of gauge the lens. So again, I don't have a precision number, but I do want to be roughly the same as the lens thickness, because then I know I'm in a relatively safe ballpark, both for oxygen and we don't want it to be too thin because then the lens is at risk of breakage. And so it's definitely a balance. Another thing that I use OCT for is looking at the shape of the lens versus the shape of the cornea. We have a wide angle OCT, which is really nice because I can see the entire chamber, but you can still do this with an OCT that has just it's a posterior OCT, but you can put on that extra lens and you can still look at the central cornea and get an idea of if that lens is matching up to the shape of the cornea. So you can see on the leftmost image here, I have my cornea and then I have my lens, and it's, there are things to correct about this lens, particularly at the limbus, but if you're looking at the shape of the cornea and the shape of the lens, that's pretty nice. And so I know if I'm going to increase or decrease my sagittal depth, I'm going to maintain kind of a nice even clearance in that chamber, where on the right image, that's a prolate cornea under an oblate lens. You can see that base curve is relatively flat. It's really quite tabletop and then turns in, as it approaches the limbus pretty harshly. And so we're going to have a really steep approach to land on the limbus with tons of mid-peripheral clearance. And that mid-peripheral clearance, again, creates issues with fogging, conjunctival prolapse, sometimes weird suction or hydraulic forces over the cornea, so it's hard to remove. And so if you ever have a patient with a lens that kind of suctions on too tight, sometimes going and looking at, hey, does my tear film look about the same as the lens, which looks about the same as the cornea from a global shape perspective? This can be really helpful. Again, that rightmost picture is going to be more challenging to remove compared to the lens on the left. When it's more even and parallel to the surface of the cornea, it'll come off, more likely to come off nice and smooth. Let's talk about, you mentioned oxygen earlier, Zach. Can we talk kind of first things on what do you hear from patients, and what are you looking for when you suspect kind of an oxygen related issue?
Yeah, so depending on the severity of the issue, you'll have this epithelial bullae, corneal edema situation occurring. And if that occurs in the center of the cornea, the patient will describe a progressive blurriness of their vision. Again, the magnitude is going to dictate when that occurs. Maybe it's 2 or 3 hours after the lens wear, maybe it's the end of the day. Now, if they have this occurring around the limbus and potentially from like an alignment issue where you're landing on the limbus, oftentimes that's not going to affect their acuity, but they describe this like dryness feeling of the lens. And you're like, when I first started fitting lenses, like, well, this makes no sense. Like your entire cornea is bathed in saline solution, like your eye physically cannot be dry, but you pop the lens off and you get this microcystic edema appearance around the limbus, and they just feel dry. So anytime a patient tells me their eyes are dry at the end of the day, I'm looking at the limbus.
That's a great point. I literally was just thinking about a patient as you were describing that on, I inherited him and trying to refit him. He's in a design that I fit, and just recently I was like, I've got to be landing on the limbus, even though I, have kind of looked at his eye periodically over time and just recently increased that chamber size, because I just sort of assumed that it was fine, but I've made all these changes, fenestrations, channels, all sorts of things because he just has these weird complaints, and so I'm anxious to see what his next lens does, because I'm waiting for that lens with the increased chamber, see if perhaps I'm landing on the limbus, some player that I just, missed along the way. But that's a really good point about, so they just have this like vague description when we're interacting with the limbus. If you do have a true oxygen, kind of a lens intolerance related to endothelial function, and, you know, 99 times out of 100, it's going to be a patient with a graft. Not always an old graft. Sometimes it's any age of a graft. It just doesn't function as well. Some steps you can take are, obviously maximizing your material decay. You can try and decrease plus in the lens power to decrease that center thickness. This patient is a previous patient of mine, and, she's roughly like a +5. And so it was hard to get, I'd have to steepen the lens so that I can use my SAM-FAP rule, steep or add minus, but then that can create fitting issues too. And so if you can decrease it or have the freedom to maybe change the base curve a little bit to steepen it to decrease plus is helpful. Yeah, material, fenestrations. Something that I found interesting that Daddy Fidel mentioned at ICSC last week was if she suspects that the patient might have issues with corneal tolerance, she doesn't let them prove it to her. She adds fenestrations right away, which was kind of an interesting approach that I may take with me as well on, these patients, in my experience, have a really hard time recovering. Sometimes lens changes make a difference, but it's a big challenge to make an impactful change in these lenses once we get this type of corneal edema and intolerance. And so part of me wonders if, doing a few of those types of things that maybe seem uh, far stretching or kind of going above and beyond, but doing it before you run into the corneal intolerance or lens intolerance, perhaps that would help with, the ability to wear their lenses. But in my experience, prior to maybe switching it up here as she suggested, is, most of these patients are headed toward a DMEC. Would
Yeah.
you agree?
Yeah, I mean, I think you would agree that lowering the center clearance, minimizing the tear chamber, if you will, is your best like ROI, simplest way to get oxygen. I mean, you talk about all these other ways to modify the lens, and I think those are nitpicky ways. Like, okay, once we've got the tear chamber down to the smallest amount we can, add fenestration, like decay, adjust the base curve. Like well, on my side, I think those are smaller things. So I would fit closer to the cornea first.
Absolutely. The tear chamber is your biggest barrier. So decreasing the sag is going to be number one, even, all the way down to potentially a corneal gas perm in some of these eyes, if they can
Mhm.
tolerate it. Just a couple other fun little pictures. You had mentioned about, those peripheral corneal elevations like Salzmann's nodules, RK scars, and, things that are elevated. Sometimes you can place like a focal lift or microvault, precision lift, whatever you want to call it, into the chamber as well. And so this is one that I did over an eye with a peripheral Salzmann's nodule. Because you can go oblate, but sometimes they're still elevated. And so, creating that like customized cutout on the back surface of the lens, they're not easy. It's fun to do, and whenever I see one, I can't turn down the challenge, so I just do it to torture myself. But sometimes they turn out really nicely, like this one did. At the same time, a little bit of touch is not always the worst thing if there is kind of some, maybe alignment over the area. I don't know that I'd want to bear down because that nodule could certainly get worse. But if there was like just a thin layer of tear film that kind of crested over the apex of the elevation, periodically I would maybe feel okay with that because previously I would have put them in a corneal GP and, touched it anyway. So, that's a nice way to kind of work around those elevations. But certainly looking at your elevation map from the beginning, finding those tallest points, as you had mentioned previously, and putting a lens on and looking at that particular highest point and see what we can do to maximize clearance over that, or I should say maximize the relationship of the lens over that. And when we talk about limbal alignment, when we have misalignment at the limbus, that's when we run into things like decentered lenses and conjunctival prolapse, which is what we're going to talk about next. So when you see conj prolapse in practice, what are you thinking when you see it?
To be simple, the lens diameter is too large, or you need a elevation specific mid peripheral adjustment.
Yeah, the
Too
first thing
simple.
yeah, it is. I would agree that there's too much space in the area of the prolapse. Like you said, like you're too big. It's an approach issue. There's too much space, which allows the forces underneath the lens in the chamber to kind of pull that loose conj up in there. The one thing that I would add is to your list is a decentered lens. If a lens is sitting low, that kind of falsely creates a large chamber in that area. So I'd also be looking at, attempting to make sure that the lens is centered so that we can get kind of a proper approach over that area of the limbus. And I would agree, like I would be looking back at my chamber size. I would be looking at decreasing limbo clearance, trying to close that, alligator mouth as much as I can over that limbal. I almost want it to be kind of tangential, minimize all that space in the mid periphery. Another part of conjunctival prolapse, kind of predicting where it might happen, is looking at the elevation map. And this one here is from a topographer where you flip over the elevation, you can see those shallow areas, and they line up exactly where that patient trapped bubbles on their insertion. And that's where the cornea falls away from us. It's further away from us in the slit lamp, so it's a very shallow area. And there's extra space between the surface of the cornea and the back surface of the lens. So if you were to swipe your parallel pipe beam, you would maybe say, oh, there's like, 1,000 microns of clearance over this area of the limbus. But across the center of the cornea, over the mid periphery, maybe there's only 100. And again, that's where like a quad sag chamber would make a difference to fix and try and minimize that excessive clearance in just that quadrant. That sounds really complicated if you've never done it before, but thankfully that's why we have consultants. That being able to call the consultant, talk to them about what you're seeing, having a map or an image like this is really going to help them make those customizations. So they'll help you do that for you. You don't have to make the call on your own, especially if it's the first time that you're doing it. So just a quick shout out to any consultants that are on the call today. We really appreciate you. And I still call the consulting, every, once a week or sometimes every 2 weeks to discuss, a problematic fit like this and just get their idea, because that's what they're trained for. That's their job, and, happy to help. I'm sure they enjoy some of the more complex approaches as well and get to test out all the good stuff that their softwares allow them to do. Zach, do you fix every conj prolapse that you see? When do
No,
you?
I was gonna say, I mean, conj prolapse is not inherently a problem. It may be indicating areas that you can improve your fit on. I mean, some individuals just have this s saggy conjunctiva, if you will, as the age, and they wear scleral lens a long time. I mean, it's a skin layer over top of the sclera, and it's just gets sucked up underneath that area. And so that, I mean, I notate it in my chart. I try to fix it, but if that's the only problem I have, the patient's been has had conch prolapse for a while, and they don't have any vascularization in that area, often leave it.
Yep. This eye right here, kind of a red hot eye. It was early in the fitting process, so this was an eye where I was like, oh, I don't feel good about conch prolapse in this one. But sometimes you just have a little bit because the cone, really drops off at the inferior limbus, and there's just a little kind of overlay underneath. During the fitting period, I'll make all the adjustments I can to minimize it. But if it doesn't completely go away and the eye is otherwise quiet, patient's not complaining about it. Sometimes they do kind of point to an area of conch prolapse and feel kind of a pinch. But otherwise, I would maybe leave it. Um, a funny quote that I've heard Jason mention a time or two is that the limbus is a wild place. And, as John Gelly's alluded to in a recent panel, is that, in sclerals, the limbus is probably the most challenging part to fit. And it's been overlooked maybe for the first 10 years of fitting scleral lenses, where now I think we're all starting to understand that it's not the haptic or the alignment curves that we need to get all fancy with. It's that really that limbal area. And if you're unsure about how to look at the limbus, this is another point where using the OCT can be helpful. In the top image, you can see that the approach toward the scleral surface is a bit steep, and it might even be coming, down within the limbus to where we might get some microcystic edema, as Zach mentioned earlier, that where the patient would have some complaints about comfort, especially after a few hours. It can kind of create what we call this tight lens syndrome feeling. And so really taking a good look at fluorescein under the lens to make sure that we're not landing on the limbus and that we're landing beyond it. That can be definitely a good part of making sure that our fits are landing as they should. The image below is where I would say that this chamber is probably too big. We're not even starting to approach the sclera as we're cresting over the limbus. The limbus is probably somewhere in this area where it goes from white cornea to darker scleral. That's kind of that transitional zone. You can see that the lens is going way past it, which is allowing for a little tissue buildup, and that's probably some early conch prolapse there, with lots of clearance over the limbus. There really isn't a documented amount, is it 50 microns? Is it 10 microns of clearance over the limbus? So it's not something that I'm typically measuring like you see in that picture there. I just used it as a reference for you as viewers to see what 200 microns looks like. But for me, I want it to be kind of as close to the limbus as I can without landing on it. And so if I can be super tangential and just super parallel to that ocular surface over the limbus all the way around, then I know that my eye is going to be, really happy and comfortable. It also helps with good centration too when you have a nice limbal alignment. And this is a great video, Zach, where you talk about making changes. You have to see what the lens looks like when it's centered.
Yeah, so just like when you're fitting an ortho K lens or a GP lens, you're going to center the lens to identify many of the parameters that are working or not working. And so this lens, as you can see, when I nudge the lens into position, like center clearance looks great. And you also mentioned a lens that decenters inferiorly is going to have some inferior conch prolapse, excessive limbal clearance. And so that's what happens when I release the lens. So in this scenario, new fitters could be deceived by the original like decentration of that lens. This image really magnifies a the misalignment of the alignment curve that needs to be tightened in that vertical meridian. If you start tinkering around with limbal clearance, it's just, you're not going to get to the appropriate lens fitting set. So tightening the vertical meridian will get you to the fitting situation that is shown on the screen now, where I'm manually holding the lens in place.
Yep. And I would say that in order to center this lens, that's quite a bit of decentering that you have there. It's probably a diagnostic lens on eye and probably a pretty toric eye. So we need both toricity in the alignment area at the limbus and in the haptic, most likely. And that's going to really improve that centering. And, sometimes new fitters get a little bit misled, they'll hold the lids away and that lens will fall. And then they'll look at the superior limbus and say, oh, not enough limbal clearance, so we're going to increase the limbal clearance. And then it actually just makes more room for the lens to decenter further because we just gave it more space up there. And so again, that's why I'm sure if you centered the lens and we looked at it, with the lens in place and we looked at the upper limbus, we'd actually have plenty of fluorescein in the upper limbus because of that misalignment that you mentioned. And so again, looking at the chamber, looking at the limbus, and even the edges of the lens too, horizontally and vertically, looking at those lens edges from a centered position is going to help you make more predictable and accurate changes to improve your overall fit. And then here's kind of, just some images of what that same video would demonstrate that if we pulled the lids away, most likely with a centered lens, we would see that superior edge lift and fluorescein pumping, chamber fogging. That's a really big source of fogging is when we have misalignment at the major meridians. On the lower image there, we can actually see that we're tight in the horizontal and loose in the vertical, which again creates that kind of teeter-totter motion with the lens on eye as they're looking around. And that's just a perfect scenario for a chamber pump to create that fogging in the post-lens tear layer. And so looking here, I can see that I have misalignment at the limbus and at the edge. This fluorescein has just a free pass from outside the lens to within the chamber because I'm misaligning at both the limbus and the edge of the lens. This is a graph or an image that came from I think it's the second paper that the Scleral Shape Study Group released, and they concluded that the further away the area of ectasia or elevation is from the center of the cornea, the more likely we are to need quadrant specific or that freeform haptic. And so it's just another kind of tip to you that says, hey, if I have a really decentered apex, decentered elevation, I'm going to need something fancy. Maybe you get away with toric haptic. Maybe, you might need a chamber specific, dual sag, quad sag type setup. But just keep in mind that if the elevation is not in the center, I'm probably going to need more than a spherical chamber, spherical haptic lens. And that you would see something like that video that you just demonstrated, Zach, with some significant lens movement and decentering. Kind of moving outward again, we've talked about the chamber and the limbal area, aligning there. And now we're going to move out into the landing curves for our last maybe 2-3 minutes is rotational stability. It's important for fitting and it's important for optics. Can you talk about your poor man's profilometry?
Yeah, so not everyone has a profilometer. They're really expensive, and to my understanding is I don't bill for it. So, or at least taking the images. So you can tell the image on the left-hand side there, there are areas of tightening on the very far edge of the lens. But if you notice, kind of that inferior temporal component there is not as white. And so if I have a spherical lens I put on their eye, I can identify that inferior temporal spot as being a steeper aspect of the sclera and maybe obviously needs less adjustment than the oblique location of the more impingement on the far alignment curve. Did that make sense, Brooke?
Yeah, you can see that inferior nasal there. You have that, a little bit better alignment, and then other places you have the compression. And so you can see where, those elevations are going to be. And using a spherical lens is going to help you identify those areas of elevation or depression to see where that fluorescein is going. Throwing fluorescein over top of that lens would probably allow you to see fluorescein pumping into the chamber as well. The other thing I was going to mention is sometimes I'll see, referrals come in and say like, oh, I just can't get this patient comfortable. Their eye's so red. And because the lens is rotating, they just tighten the edge, tighten the edge, tighten the edge. And so sometimes we'll see a lens that's really tight because they've just been trying to get the lens to stay in place, where they're actually, like you mentioned before, not being aggressive enough with the toric haptic or the quad specific haptic so that you can have alignment and a white eye like the other one. Zach, we have just a couple minutes left, I think. Ariel, correct me if I'm wrong. So we'll cruise through just a couple of our last slides and hit the high points here. We're just going to talk a little bit about scleral elevations. We have pingueculas that we can go around, and we have a couple options there. We have notching, which is typically hand done. The lab can do it for you if your lab does it, or you can do it by hand in your practice. And some of our speakers today do a little bit of that, so you can connect with us offline for instruction on how to do that. You can do a impression-based lens over those types of elevations, as well as lathe-driven designs like we have in this computer-generated image over here, where you can measure the pinguecula, measure the diameter and the height to create that little vault over it. And these patients really tend to love their lenses with those little edge vaults on it because they are just so much more comfortable and their eye feels so good rather than having the edge of the lens kind of digging into their scleral elevations. The patient comfort, can you talk about edge lift, Zach, and
Sure.
patient awareness?
Like I said, I used my history to identify problems with the patient's lens. And so a patient that notices immediate discomfort in their lens wear is more often identifiable with a lens that's too flat in at least one of the meridians. And oftentimes it's the flat meridian. So when they blink, their eyelid catches that flat area and it almost feels like this foreign body sensation. Generally, that improves as the lens settles on the eye versus in contradicting to what I was mentioning previously is if there's irritation at the end of the day, that may be more of a limbal adjustment. So again, using a patient's history to dictate what are you looking at? I mean, you're looking at everything, but that'll drive you to fixing the issue that's most present for the patient.
Yeah, and that discomfort after several hours, like you were saying, that kind of comes in that tight lens syndrome where the lens is settling, it's hitting the limbus like you can see in this image here, and then you get that kind of microcystic edema over the limbus. Because sometimes the lens looks fine at dispense and you have limbal
Mhm.
clearance, and then it settles into where you actually land on the limbus. And so again, it's just really important that you allow yourself the time to take the lens off and take a look at the ocular surface. You can even see some kind of scleral lens edge guttering there in that picture. And, this one here needs, probably a couple adjustments, bigger chamber, a little bit more depth overall to get that lens to be more comfortable for the patient. And then lastly on edge lift, when we do land on the limbus, sometimes there's a ton of edge lift like you can see in this one here. And so is it edge lift or is it limbal bearing? Just keep that in mind when you're seeing these things. Um, we kind of talked about the microcystic edema where the patients have that discomfort and that dryness sensation, that tightness sensation. And so certainly looking at that, sometimes this is where we can actually open up the alligator mouth and get a wider approach over the limbus. Usually it's, extending the chamber size to get out past the limbus. So there's a few things that, depending on your lens design, take this to your laboratory and they can help you address that. And maybe the final tip, Zach, would be impression rings. Lens comes off, patient says, I can see where my lens was sitting. When do you chase it and when do you not?
Magnitude, I suppose. If it's a mild impression ring, I probably leave it. If it's a more significant one that's causing the vessel engorgement and their eyes has this rebound redness, you're likely probably too tight.
Yeah, usually what I ask the patient is like, is it back to normal by the morning? Is your eye red in the morning? And I'll liken it to like just like when you wear socks or a watch. Your tissue has a little indentation, and that's because we have fluid underneath our surface tissues, and that a little indentation is fine. Like this picture right here, I probably wouldn't change anything. If I took the lens off and I actually had like conjunctival staining or like what I call a gutter, where I would be concerned about like tissue hypertrophy over time from chronic staining, then I would be, adjusting that. But kind of an even ring all the way around that bounces back the next morning without residual redness, then I'm feeling pretty good about it.
I would also point out it's on our slides written in, but we didn't specifically say is with edge lift, the patient can often identify the location of the discomfort versus the microcystic edema. It's really difficult. They say, I don't know, my eye's just dry. Like it's hard to pinpoint that. And so that's again another historical thing that you can ask your patients to drive, like what location do I need to primarily focus adjustments on?
Yeah, that's a good one too. I kind of have them squeeze their lids and they can kind of see that area of rotation. Last comments, and then we'll do questions and kind of transition into our section here is remember the conjunctiva is dynamic, but the lens is not, and that the final lens combination is the final lens is a combination of patient satisfaction as well as us accepting what the lens looks like and how that impacts corneal health. So, um, sorry if you guys had your videos on for a long time. I had them out of my way, so sorry if I was making you wait, but we should be all good. Thanks, everyone.
Wonderful. All right, so now we're going to go over about 30 minutes. We're going to spend about 30 minutes going over some questions. So go ahead and throw in all of your questions in the Q&A. So we'll start with some of the ones that are already in there. One of the questions, I will give this to you, Dr. Kusner, since we haven't heard your beautiful voice in a little while. Do you consider an overkeratometry to understand how the lens sits on the eye?
Did you say overcase? Is that what you
Yes.
said?
Yeah.
Overcase.
Yeah, I'm basically looking for that to look for any type of like flexure. So usually what I'm doing with my during my workup is I have my technician do an OCT and an over refraction and an auto refraction, auto K's over, and that kind of tells me a couple things. One, if it's what my residual prescription is, and if there's any flexure, and that just tells me if I have scleral misalignment.
Great. Anybody else want to add anything?
I
I
don't
don't
do
really
Ks,
say
but usually in
more.
your over refraction, if you see cylinder that matches the shape of the meridians of rotation of the lens, if it aligns to your steep meridian, flat meridian, it's going to be flexure.
Mhm.
Oh.
I don't use it.
I don't use it, but I think it depends on the design of lens you're using. The thicker the lens, the less likely it's going to flexure. But also, I mean, how appropriate your alignment curve is going to dictate are the lids bending this lens?
Mhm. And so while we're on that point, when would you consider, thickening a lens versus it being like a peripheral curve issue?
The only time I'm really doing that is some of my lenses that I fit are pretty thin to start out with. If I really think that it's flexure that way, but most of the time I'm not adding like a flex control or thickening it for the most part, unless I mean I just had a guy this week that broke his lens on INR because it was a pretty thin lens. So for that situation, like sometimes I'm thickening it on purpose, just so that the patients can handle it a little bit better. What do you guys think?
If you have an alignment curve issue, you're gonna have other problems, fogging, decentration, comfort. So you'll probably, outside of a lens like looking perfect and the patient's fine, I don't know. I mean, I don't know if I've thickened the edge of a lens ever.
Agree. I agree.
Hmm. I kind of do the
I would
opposite
not.
usually. I'm usually thinning it out. But
Right. So we talked a lot about sodium fluorescein staining. Do you guys ever use lissamine green staining?
I think it's fine. Sometimes if you have fluorescein in the bowl and you're assessing it and you kind of want to see the edge again, you could do lissamine. That way, you can see the difference between the two. I would say 95% of the time I'm only using fluorescein, but every once in a while I'll throw lissamine in there.
I would agree. Lissamine has a place if you want to look at edge edge issues for sure, but I don't use it very often.
Fluorescein is definitely easier to see, and even if they have fluorescein in the bowl and you want to check for chamber seeping or chamber pumps, if you put fresh fluorescein in, it's going to illuminate better than the rest of the fluorescein. So if you were kind of getting going in scleral fitting, I wouldn't go out and buy a lissamine green, just to because you're going to use it. But um, again, it's a nice to have, but not a must.
The better
Mhm.
use of it for scleral wearers is looking at lid wiper epitheliopathy.
I was waiting for
Mhm.
Jason to say that. I was like, he's gonna say something about the lid wiper.
Yeah,
Do you want to expand on that, Dr. Jedlicka?
just that, most scleral lens wearers have pretty bad lid wiper epitheliopathy from rubbing against that massive plastic surface 10,000 times a day. So
Mhm.
it's something to
What
look at.
what do you typically do to treat lid wiper epitheliopathy if you see it?
Just lubricate as much as you can and occasionally punctal occlusion, whatever you can do to increase hydration. I have a lot of patients on using MIBO, for example, another thing. It's just really important to let patients know that sclerals are awesome. Don't get me wrong. I love them, love them, love them. But there's issues with them. And there's not a patient out there that doesn't have lid wiper epitheliopathy due to scleral lens wear. And so early in the fitting process, we talk about it that you're wearing a scleral is like giving yourself dry eyes from an outside the lens perspective, not inside. And
Mhm.
so we have a lot of our scleral lens wearers use artificial tears just like their dry eye patients, not because their eyes are dry, but to wet the surface and lubricate the lid.
I'm glad you mentioned punctal occlusion because I think punctal occlusion sometimes gets a bad reputation in eye care. And certainly there are eyes that you don't want to do it. But these patients have a larger surface to cover and they just naturally need a larger tear lake to be able to spread it. And so if I have a quiet eye, I would punctal occlude all of my scleral patients. Without hesitation. I like dissolving punctal plugs, the 3 to 6 month dissolving plugs, and that way they don't have a permanent plug in there, and I really like it.
I agree. I agree. I use punctal occlusion more in scleral lens wearers than any other population, probably.
Mhm. Very good. Another question we have is what is the age limit for fitting a child in scleral lenses?
Very case dependent, I think. Depends on, the risk versus benefit. Is it just because they have 5 diopters of corneal astigmatism and like then I would really, and they're 10 years old, I would try and get that kid in a corneal GP, I think. Um, where,
Yeah, I don't think there's a
16,
limit,
17,
right?
18, there's like that's kind of a transitional time. And I've had younger kids, babies who not quite a baby, but I've had young kids that we put a scleral in for like extreme corneal issues.
Yes.
They've got issues beyond the cornea and the parents just need something to protect the eye. Those are kind of the extreme cases where we'd fit a young one.
There's no age limit if the situation calls for it and the parents can do it. I've seen 3-year-olds in sclerals because they had an innervation disorder to their eyes where they had no corneal sensation and they had to wear it. They had
That's the
to.
same reason I
Mhm.
I did mine too, was the lack of
Yeah.
pain in the cornea, and so she was
Yeah.
naturally like scratching her eye all the time.